Two, one. Please start, sir. We are live.
Hello, good morning, everyone, and a very warm welcome for this excellent webinar and clinical updates in hematological malignancy. Great Sunday to everyone. It's a pleasure to welcome and invite Dr. Ankur Mittal, the program convener. He is a consultant medical and hemato-oncologist and bone marrow transplant physician at prestigious Monday Oswal Hospital, Ludhiana. So, good morning, Dr. Ankur, sir. The stage is set. We look forward for a welcome and introduction to start the proceedings, please. Over to you, Dr. Ankur, sir.
Good morning, everybody, and thanks, Torun, for the warm welcome. Not taking much time, I just welcome my all dear colleagues and the friends. Today, I'm really excited and elated to welcome you all for this academic feast today. Today, our focus would be again to learn and relearn from each of us regarding the various hematological malignancies and the recent updates regarding the treatment and management for the better clinical outcome. I'm looking forward for an interactive session today, and not taking much time, I hand the dice back to the organizing committee to welcome the speakers and to proceed for the proceeding.
So thank you. Thank you so very much, Dr. Ankur, sir, for this warm introduction. Now we move forward, and the first session is, of course, the academic partners are Novartis. It's again a pleasure to invite Dr. Ankur Mittal, who is going to talk upon early versus delayed ruxolitinib for MF. And of course, over to you, Dr. Ankur Mittal, sir.
Thank you, and I'll try to wind my topic within 15 minutes. I'll not take the luxury of being an organizing. We all know that myelofibrosis is a tricky topic, and it's sometimes very difficult to have the outcomes in the patients. So this session is sponsored by Novartis, and thanks to the Novartis for all. I'll be discussing that this is an individualized case, treatment-based decisions. So our patient is like in January 2016, one patient, 50 years old male, who presented with fatigue, night sweats, splenomegaly, which is 5 centimeter below the costal margin. WBC counts were 12,000, and there's no blast with an hemoglobin of 14 and platelets 5,60,000. The bone marrow biopsy was planned, which shows the features of myelofibrosis. And on molecular analysis, BCR-ABL was positive, while JAK2V617 is positive. So our patient is suffering from early myelofibrosis, and we all know the scoring system which we follow is the DIPS scoring system, and our patient lies in an intermediate risk 1 category, so which was based on age, WBC counts, peripheral blast, constitutional symptoms, and the hemoglobin. So would we recommend the treatment at this point or not? That's the decision which we all have to take. So we all know that the management of myelofibrosis is based on the disease burden and the disease risks, what are the clinical outcomes. But our goal of therapy is to control the symptoms or to modify the natural course of the disease. So as per the NCCN 2020 guidelines, the treatment in low-risk patient and the high-risk patients, the patients of low risk who are asymptomatic, we can just observe or go for the clinical trials. Where the symptomatic patients, we have to use some treatment modalities like ruxolitinib. While in high-risk patients who are transplant eligible, so we offer them the allogenic hematopoietic LOSCT. While those who are transplant ineligible, ruxolitinib, fedratinib, or clinical trials. And in transplant ineligible with anemia, we try to maintain the hemoglobin levels, and other clinical trials we enroll the patients. So at the same time, we have seen these patients have constitutional symptoms. And if I divide the patients depending on the constitutional symptoms, the most of the patients who have intermediate low risk, they have they have less of constitutional symptoms, while the higher the DIP score, they have higher of the constitutional symptoms and have high rates of abnormal CBCs. And if we, from the observational studies, the landmark survey, the observation studies evaluate, there are many other symptoms which are not recognized by the MPN. These symptoms are like difficulty in sleeping, numbness, dizziness, pruritus, abdominal discomfort, sweat, and fatigue. They might be correlated with MPN or may not be. So should we consider the treatment for the symptoms? Yes, if we say we have this scoring system, that is the MPN 10 total symptom score, in which we score fatigue, early satiety, abdominal discomfort, inactivity, problems with concentration, night sweats, itching, bone pain, fever, and unintentional weight loss. So we score them from 0 to 10, depending upon the absence to the worst on the basis of imaginability. And these are the pathophysiological, the background why these symptoms are there. So if the score is more than 5, it has been suggested to start the treatment, and might be we get benefit from the treatment. And for the constitutional symptoms, symptoms respond to the treatment splenomegaly, or splenomegaly has been treated by non-ruxolitinib based treatments like hydroxyurea, cladribine, radiotherapy, splenectomy, and 40% patients have response, but that is transient. But as per the COMFORT trial, if we use ruxolitinib in myelofibrosis, the symptoms related to the splenomegaly has drastical improvement with the use of ruxolitinib as early instead of delayed. And if we talk about the other risks as per the JUMP trial, the change in the FECT line total score or FACIT fatigue scale, even if high risk, low risk or intermediate risk patients, those who are on ruxolitinib, there is approximately 40 to 54% patients, they achieve response by using this molecule. So if we use ruxolitinib based treatment in IPSS1 patients, high response rates and low toxicities has been seen. And the spleen response at 24 weeks is in COMFORT-1 trial is about 41% to, and COMFORT-2 it is 32% patients who responded. In JUMP trial or ROBUST or other Italian studies, it's around 50 plus minus 10. So the patients who have started on ruxolitinib early, their response rates are better, and the factors which were predicting to the response rates are IPSS scoring, prior treatment, or those at 12 weeks are the factors which affects the response, early response with ruxolitinib, while others have the favorable response. Similarly, if we talk about the anemia, the patients who have received ruxolitinib treatment in myelofibrosis, the anemia response rates are significantly good, and we get early responses. Grade 3, grade 4 incidence of anemia has decreased by 45% in patients of in the COMFORT trial, and in COMFORT-2, 42% patients have shown the response rates. So the other worry is the dosage of ruxolitinib in the patients who are anemic. We can start at a starting dose of 10 milligram BD for 12 weeks and followed by upward titration depending upon the response. And we have seen that 56% patients, there is 50% reduction in the spleen length at 24 weeks. So the response rates were seen in both transfusion dependent and non-transfusion dependent patients. And the median levels of hemoglobin are maintained in the patients who have started the ruxolitinib even at low doses at 12 weeks in different trials, and this results has been maintained up to 60 weeks, a median dose. So our patient was started at ruxolitinib 20 milligram BD, and the symptoms disappeared with the use of early ruxolitinib instead of delay. But at the same time, if we see the patients who have higher molecular mutations, high risk mutations has been detected, like ASXL1, IEZH2, or SRSF2, or IDH1 and 2 mutations, which are done by the NGS-based panels. The patients, the overall probability of overall survival is markedly reduced when patients have high risk mutations, and cumulative incidence rises as we proceed. So do we have any new prognostic scoring system which have these mutations with them? So that's the scoring is mutation enhanced international prognostic scoring system. I'm not aware how many of we are using this scoring system, but in this we have CALR or other high risk molecular mutations are there, and we have classified the patients as low, intermediate, and high risk mutations. And depending upon the risk stratifications, the outcomes vary. So the 10-year outcomes in low risk patients are about 83%, while the median 10-year survival is 39% in intermediate, and lowest in high risk patients with 12% at 2 years. So the long-term survival data has also shown the same thing. If we use ruxolitinib as early, the median overall survival has not been achieved with ruxolitinib arm, while it is 4.1 years the patients who have received other treatment regimen-based therapies apart from ruxolitinib. And the other thing which I need to highlight, the patients of allogenic stem cell transplant in primary myelofibrosis. This is a retrospective data from EBMT or ELN International Working Group. The patients with intermediate 1 risk or age less than 65 years with refractory or transfusion dependent anemia or the peripheral bone marrow blast less than more than 2% or adverse cytogenetics, or the patients who are triple negative or ASXL1 positive. We use the molecular risk classification and identify the patients who are LOSCT eligible, and patients with intermediate second or high risk category with age less than 70 years are included. There was no difference in 5 years overall survival between myeloablative or RIC conditioning regimens, 53 or 51%. The median patient age was 52%, and extensive chronic GVHD was seen in 27 and 31% of the patients respectively. The non-relapse mortality was at 1, 3, and 5 years are 25, 32, and 34% respectively in MAC group, while 26, 32, and 34% in RIC group, so comparable. In the MAC cohort, the worst overall survivor and NRM with older age group, but with unrelated donor. While for the RIC, the worst and NRM were associated in the age group of 60 to 70, compared with the younger recipients and mismatched donor or poor performance status. So this all data is retrospective. We have to consider that there is no randomized trial head-to-head with autologous stem cell transplant versus the JAK2 inhibition is still lacking. So the data is still yet to be matured to say which is better. So how the next question arises in our mind, when to stop the ruxolitinib and how we can say that ruxolitinib should not be continued further, or when we can say there's a resistance. So what are the predictive factors in which ruxolitinib discontinuation was seen? So the patients who have high DIP score or transfusion dependency is there, or the platelet counts are less, or who have unfavorable karyotype, these are the patients who more likely to discontinue ruxolitinib with due course. So when we say there is a lack of reduction in the spleen size or persistence of constitutional symptoms under ruxolitinib is uncommon. But practically, if we say when JAK2 inhibitors are refractory, so the analysis where the ruxolitinib refractory was defined is when the splenic volume reduction is less than 10% by MRA or CT, or less than 30% spleen size decrease from the baseline spleen size 10 centimeter from the last evaluation, was that more than 3 months, then we say the patients are refractory to ruxolitinib. At the same time, ruxolitinib with relapsed myelofibrosis, the loss of confirmed clinical response to ruxolitinib is not uncommon. Most of the patients who discontinue ruxolitinib by 3 years did so primarily because of the relapse or the disease progression. And if we define relapse is that of the consensus guidelines in IWG-MRT or the ELN group, the relapse is defined as no longer meeting criteria for at least clinical improvement or loss of anemia or spleen response, which are persisting for at least 1 month.
Sir, sorry to interrupt. You have 2 minutes to conclude, please.
The ruxolitinib-related cytopenias is comparable to the patients with higher platelet count, spleen responses in low platelet patient is low, and the 5 milligram BD ruxolitinib doses has shown limited response, and continued treatment should be limited to the patients for whom the benefit outweighs. So if I conclude the session, the ruxolitinib in myelofibrosis, the influence of disease stage on the quality of response. The spleen or the symptoms responses are lower if the time interval between myelofibrosis diagnosis and the start of ruxolitinib is more than 2 years. The larger splenomegaly and higher total symptom score is there. Transfusion dependency or lower platelet count at the start, or IPSS intermediate 2 scoring or high risk patients. The influence of ruxolitinib doses are early myelofibrosis patients may tolerate a higher ruxolitinib dose. Patients starting with higher doses have higher rate of spleen response. Use of ruxolitinib doses less than 10 milligram BD may also results in the reduced efficacy. I must say, means considering higher doses of ruxolitinib or starting ruxolitinib at first line, the main concern in Indian scenario is the cost. Even though the patient assistance program is there, but still many of our patients are unable to afford ruxolitinib, even though we would like to start it early. Thank you, and I hope I have.
Yeah, thank you. Thank you so much, Dr. Ankush sir, for such a brilliant presentation and on time, but still we have a minute to go. Any questions? Anyone would like to ask any questions? from the audience or from the faculty? Anyone who have one or two questions? Else we will. So Dr. Meet, we can see you. Any questions for Dr. Ankur? Dr. Priyanshu, any questions before you take the next presentation?
I think so. You explained well.
Great. Yeah, thank you so much. So thank you so much, Dr. Ankur sir. And now we move to the next session, and that's the next talk, brilliant one, Nilotinib, a journey of 10 years. And it's a pleasure to invite Dr. Priyanshu Chaudhary, consultant hemato and medical oncologist from Mohali. Hello, sir. So you're all set. Over to you, sir.
Okay, thank you. Good morning, everyone. Thank you, Novartis, and thank you, Dr. Ankur, for giving me this opportunity. And so we'll be discussing nilotinib, a journey of 10 years today. So we'll start with the clinical case. A 29-year-old woman diagnosed with chronic myeloid leukemia, a baseline TLC of 84,000, a B3A2 transcript, and showing 90% of the examined metaphases as having Philadelphia positivity with no additional chromosomal abnormalities, no splenic enlargement, and a low so-called risk score. So what are the current and evolving goals for CML treatment? The traditional goals have been to prolong survival and to prevent disease progression. The recent one include achieving established treatment milestone, that is a complete cytogenetic response, an early molecular response, and a major molecular response. But all this changed in 2020 when the ELN guidelines mentioned that the TFR should be the goal of therapy now. So achieving minimal residual disease and to discontinue treatment, that is TFR, is the primary goal for now. So what would be the proposed first-line therapy for this patient, whether it's imatinib 400 mg OD, imatinib 400 mg BD, nilotinib 300 mg BD, dasatinib 100 mg once daily, or bosutinib, or something other. So what is the current sequential TKI therapy regimens? So most of us usually start with imatinib, and for second line we have nilotinib, dasatinib, or bosutinib if nilotinib and dasatinib are contraindicated. And in patients with T315I, ponatinib is the drug of choice. For third line, we can switch over to other second generation TKI which have not been used, ponatinib or stem cell transplant. For fourth line, investigational TKIs or a repeat stem cell transplant is usually the drug of choice. So achieving an early molecular response, how important is it? Early molecular response is defined as an IS ratio less than equal to 10% at 3 months of starting therapy. So this 2014 analysis showed that early molecular response predicts outcome in patient with chronic myeloid leukemia in chronic phase treated with frontline nilotinib or imatinib. So EMR, an achievement of an early molecular response showed that it had an increased likelihood of MR 4.5 response. It led to a reduced risk of progression and an improved overall survival. So, so in this study, patients were randomized into 3 groups. 2 received nilotinib at a dose of 300 mg twice daily and 400 mg twice daily respectively. And the third group was imatinib 400 mg once daily. So if we look at these charts, we can see that around 10% of the patients could not achieve an early molecular response with nilotinib, while almost a third of the patient on imatinib could not achieve an early molecular response. And if we see the next graph in which this data has been analyzed based on the SOCAL risk stratification, the difference is much more marked in the high risk SOCAL index patient. 86% with nilotinib 300 mg twice daily achieved an EMR. In the nilotinib 400 mg group, around 82%, but only 44% of the patient in the imatinib group achieved an early molecular response. So this difference is quite large. So overall, if we see an EMR was achieved in 91% of the patients with nilotinib 300 mg twice daily, which is the standard dose which we use. Now coming to the analysis of the NS and ND study, the cumulative incidence of MMR at 10 years, if we see, was 77% to 80% in the nilotinib arms versus 62.5% in the imatinib arm. And if we see by 5 years of therapy, almost 77% of the patient on nilotinib achieved an MMR, but only 60% of the patient on imatinib achieved an MMR. By the 10-year analysis, this percentage increased to almost 80% in nilotinib arms, and it was still at 62% in the imatinib arm. So patients on nilotinib achieved higher rate of MMR both at 5 years and 10 years. Now coming to MR 4.5, that is deep molecular response, again around 50% of the patient on nilotinib achieved this at 5 years, increasing up to 61% at 10 years. Only 31% of the patients on imatinib achieved an MR 4.5, increasing up to almost 40% by the end of 10 years. So almost 60% of the patient would not be achieving an MR 4.5 in the imatinib group. Now, coming to the disease progression, we had the earlier 5-year analysis and the latest 10-year analysis. So only one patient in the nilotinib arm, both of the arms had progression to accelerated phase of blast crisis in the year 5 to 10, and 5 patients on imatinib progressed to accelerated phase of blast crisis in this period of 5 to 10 years. And overall, if we see in the 10-year analysis, 24 patients on the imatinib progressed to accelerated phase of blast crisis, which is quite higher than the patients who were on nilotinib. So overall survival, if we come to the overall survival, there was no difference in the overall survival seen at 5 or 10 years, but there were fewer deaths due to CML and the nilotinib treated patient compared with the imatinib treated patients. So coming to this case which we have started, patient was started on nilotinib 300 mg twice daily and tolerated the therapy well. The BCR ABL-IS ratios were at 3 months 0.55. EMR was achieved, 6 months 0.047, 12 months 0.0098, 18 months MR5, and she has maintained the MR5 since then. So she has attained all her milestones very well. Now with 2 years on stable response, she expresses a desire to have a baby. So what can be the advice to her? Whether you do not stop the TKI therapy as it's too dangerous. So you can stop the TKI therapy and try to conceive. You wait for at least another year. You stop the TKI therapy, and then if after 6 months there is no recurrence of the disease, you can try to conceive or some other. So we see what are the recommendations. So these are the steering group recommendations derived from patient-physician discussion. The following factors should be considered before attempting a TFR. Patient need to be well informed about TFR, well motivated to discontinue treatment, but not under pressure to stop therapy. Patients should fully understand that molecular recurrence is not a failure and the treatment will be restarted. And the molecular monitoring test results should be available within 4 weeks. So with the discussion, we should know are the patient ready to attempt TFR. So nilotinib is the only TKI adjusted for discontinuation. Discontinuation of treatment may be considered in eligible pH positive CML patient in chronic phase who have been treated with nilotinib at 300 mg twice daily for a minimum of 3 years if a deep molecular response MR 4.5 is sustained for a minimum of 1 year immediately prior to discontinuation of therapy. So this is very important criteria. Eligible patients who discontinue nilotinib must have their BCR ABL1 transcript levels and a CBC with differential monitored monthly for 1 year, then every 6 weeks for the second year, and then every 12 weeks thereafter. So this is the NEST Freedom Study TFR following frontline nilotinib in patient with CML in chronic phase. The analysis at 122-week data. So the design of the NS Freedom Study was as follows. It was a single-arm phase 2 study which included adult patient with CML chronic phase, B2A2 or B3A2 transcripts who had received at least 2 years of frontline nilotinib and who had a MR 4.5 at screening. So the patients were then taken for a consolidation phase of 52 weeks. At the end of 52 weeks, if they had a sustained DMR, then the patient were discontinued and the patient was taken into TFR phase. If there was no sustained DMR, then again continuation phase was continued and the patient was awaited for sustained DMR, and then again a TFR phase 2 was taken for that. The patient were analyzed for treatment and nilotinib was reinitiated following loss of MMR. So The monitoring requirement was as per the guideline monthly for 1 year, every 6 weeks for year 2, and every 12 weeks and for year 3 and beyond. Nilotinib was reinitiated within 4 weeks if loss of MMR was documented, and following reinitiation, patients were monitored monthly until MMR was re-established. So in this study, we see at 3.7 years, 48.7% of the patient had maintained a TFR, and the long-term data showed sustained TFR in around half of the patients. And very importantly, over 98% of all patients who reinitiated treatment due to loss of response regained MMR with nilotinib, and over 90% regained MR 4.5. Patient who had lost deep molecular response rapidly regained molecular responses. Almost 99% of the patient who resumed nilotinib treatment regained MMR, and around 92% patient had also regained MR 4.5 by the analysis cutoff, that is at 3.7 years of. So if we see around 50% of the patient regain an MMR by 7 weeks, and another almost 50% patient regain MR 4.5 at 13 weeks. Then the same methodology was used for in the NS top in the second line nilotinib treatment. So it was again a phase 2 study with patient with CML-CP, at least 3 years of TKI therapy and at least more than 4 weeks of imatinib treatment, and then nilotinib for at least 2 years. Non-documented MR 4.5 at the time of switch to nilotinib, and achieved MR 4.5 on nilotinib. So again, it was a similar trial design, consolidation phase of 52 weeks, and if there was no confirmed loss of MR 4.5, then TFR phase. Similarly, if there was a loss of 4.5, MR 4.5, then continuation phase for another 52 weeks and a TFR2 phase. So the results of this study showed that TFR at 3.7 years was 46%. All but one of the patients were in MR 4.5. Among 61 patients with successful TFR in the previous 2.8 year analysis, one patient had confirmed loss of MR 4 by 3.7 years, and 2 patients discontinued the study, one due to adverse effect, that is polycythemia vera, and one due to patient decision. The estimated TFS rate at 3.7 years was 50.3%. So if we see here, estimated TFS rate at 3.7 years is 50.3%, and the 3.7 year TFR rate is 46% in the second line, which is quite impressive. The response to retreatment, around 95% patient regained MR4, and 93.2% also regained MR 4.5. Among 25 patients who resumed nilotinib due to confirmed loss of MR4, all 25 regained MR4, and 96% regained MR 4.5. Again, 97% patient regained MMR, and 91.2% regained MR4 and 4.5. In patient who resumed nilotinib, BCR-ABL1 international IS levels decreased rapidly over time. So if we see again, 50% of the retreated patient regained MR4 by 11 weeks, and 50% of the retreated patient regained MR 4.5 by 13 weeks. So this is very important. If we see that the patients who were discontinued, but they had a loss of MMR, again, the response was pretty good with nilotinib within almost within the first 3 months. So BCR-ABL over time, the IS ratios had decreased over time, and if you see, almost all the patients had achieved a very good response by 192 weeks. Again, the majority of the patients who regained MR4 or 4.5 had stable responses 48 and 96 weeks later. At 96 weeks, 40 out of 56 patients had an MR4, and 37 out of 55 patients had an MR 4.5. So coming to the safety profile during the TFR, there were 13 deaths in the NEST, 10 in the NEST Freedom, and 3 in the NEST Top studies. The overall, if we see the cumulative adverse events have decreased over time, having been highest in the consolidation of the first 48 weeks, and decreasing significantly by the fourth 48 weeks TFR time. So the adverse events that may have an adverse impact on patients' quality of life tended to decrease in frequency over time during TFR. The major adverse effects which were analyzed were GI disorders, infection and infestations, musculoskeletal and connective tissue disorders, and general disorders and administration site conditions. All these adverse effects decreased over the time. By the end of fourth 48 period, they were pretty much less common compared to the consolidation phase. So the in this patient went off therapy with monthly follow-up for 6 months and 2 monthly follow-up for 1 year. Post lockdown, she joined her workplace and is now doing clinically well. So coming to the overall reported adverse events with nilotinib and imatinib, almost all the patient had some grade of adverse events. But if we come to grade 3 and 4 side effects, we can see that in the patient who had nilotinib, they had slightly higher transaminitis, rash, headache, while the patient on imatinib had more of hematological toxicity, anemia, neutropenia, as well as diarrhea. So these are all the side effects were on the expected lines. Coming to the cardiovascular events in the patients who were on nilotinib, in both the studies, in both the groups of nilotinib, the cardiovascular events were higher compared to imatinib, but the rate of cardiovascular event after 5 years in each arm was similar to the rates in the first 5 years. So the cardiovascular events were also analyzed according to the Framingham high risk scoring. The patients who were in the Framingham high risk group, that is the Framingham risk category, a risk of more than 20%, almost a quarter of these patients had a cardiovascular event compared to just 3% in the imatinib arm. So this is one subgroup which we have to be careful, because although the numbers are not very large, but still the percentage is quite high in this subgroup. So the summary of nilotinib. Nilotinib results in a higher rates of early and deep molecular response compared to imatinib. The early and deep molecular responses predict better long-term outcomes for patients with CML chronic phase. MMR and deep molecular response rates were higher throughout the follow-up period, and the observed 10-year OS rates were similar. Nilotinib results in a longer risk of progression and a lower risk of death due to advanced CML versus imatinib. TFR following a minimum of 3 years of nilotinib first-line treatment combined with having a sustained DMR is safe and achievable. TFR is increasingly seen as an important clinical goal for patients. The safety profile of nilotinib is well established and is distinct from that of imatinib. Cardiovascular events occur in some patients treated with nilotinib, most often in patients with risk factors or comorbidities. Results from the final NST-ND analysis continue to support the use of frontline nilotinib 300 mg twice daily as a standard of care treatment option for patients with newly diagnosed Philadelphia positive CML CP. So the indication of nilotinib, we all know, both in first line as well as second line, it is approved for both adult and pediatric population. So we have been celebrating 10 years of nilotinib. So I think so that will be all from me. Thank you, and over to the.
Thank you, Dr. Pranshu, and thank you. And we are on time. We still have 2-3 minutes with us. So if any questions or any queries, we can take that questions right now. Okay, so if there are none, so we can switch to the next session. Due to some urgent work, Dr. Sachin Yadav has not yet joined, and so we are proceeding to our next session. That's Dr. Dipanjan Halder. This session is sponsored by the Aureate company. Brief regarding Dr. Dipanjan. Dr. Dipanjan is a consultant hematologist and hemato-oncologist with the BMT physician at Jupiter Hospital, Mumbai. He is a dynamic personality, and I know him well. We have met 3-4 times, sir. He'll give talk on the management of mucositis in BMT patients. Over to you, sir.
Thank you, Dr. Ankur, for the opportunity. Really look forward to an interactive session. If I may, please be allowed to share my screen.
Yes, sir, you can share your screen, sir.
Yeah, okay. So I hope my slides are visible.
Yes, sir, they are.
Okay, and I'm just putting it in the slideshow mode. So yeah, so I'll be talking about management of mucositis in bone marrow transplant patients. So often we discuss lots of things about bone marrow transplant, right? Regarding the conditioning regimens, regarding the intensity of the conditioning, regarding GVHD, the post-transplant complications. But this is one aspect which is discussed not too frequently. So I mean, I can remember last few BMT meetings, and there has not been any talk on mucositis. So I was pretty surprised, and it was a welcome surprise for me to discuss this topic. because this is one very essential aspect of supportive care in the BMT patients, and often we tend to kind of not ignore it, but not give it that much importance as it really deserves. So I'll be focusing on providing evidence-based management about management of mucositis in the bone marrow transplant patients, and to identify various therapeutic measures to reduce the severity of oral mucositis in patients undergoing bone marrow transplant. So as we all know, this is just a brief introduction. So in the autologous bone marrow transplant, we use the patient's own stem cells, and after we have harvested the stem cells, we could cryopreserve it, and we give the patient very high dose chemotherapy, and then we go ahead with reinfusion of the patient's stem cells. In allogeneic stem cell transplant, we collect the stem cells from the matched donor or half matched donor. We could be processing it, and then we give the patient high dose chemotherapy and plus minus radiotherapy, and then we go ahead with reinfusion of the stem cells to the patient. Now, because of the high dose chemotherapy or plus minus radiotherapy that we give to these patients, there are various complications that we see during the course of our bone marrow transplant. And of them, if you see that most of the patients develop some degree of mucositis, which is basically a toxicity of cancer therapy that affects the lining surface of the mucosa. So it could be of the mucosa of the oral mucosa or the mouth or the rest of the GI tract as well. And these patients present with erythema or ulcers. So along with mucositis, obviously, there are various other complications also in bone marrow transplant. For example, nausea, vomiting, bone marrow aplasia, diarrhea, GVHD, infection, bleeding, and transfusions, and various other lung complications as well. So this is what I was talking about. So if you see the prevalence of oral mucositis, so especially with autologous as well as allogeneic transplant, in whom we are giving myeloablative conditioning, is extremely high, and it can be some degree of mucositis is seen in majority of the patients, and hardly there will be a single patient who has not developed any mucositis. So it ranges very high, like 75 to 99%, both in autologous as well as allogeneic BMT. And if we see that oral mucositis, so patients experiencing severe grade of oral mucositis was slightly higher in allogeneic BMT compared to autologous BMT, especially in those patients who received myeloablative conditioning. This is another such study. We see that so the prevalence of mucositis across various grades is quite high, and especially those patients doing autologous as well as allogenic myeloablative bone marrow transplant, as compared to allogenic non-myeloablative transplant, in which the mucositis is significantly lower. Now, various factors have been looked into, like to be associated with developing of mucositis. For example, periodontal gingivitis, periodontitis, edentulous, whether the patient is smoker or non-smoker, but there has been some association, but none of them have been quite significantly associated with development of oral mucositis. So as I've already mentioned, mucositis might not be just limited to oral cavity, but the entire GI tract can be involved. And this is generally seen in the first 2 weeks following the transplant. And among the most important culprits are the high-dose melphalan, high-dose busulfan, cyclophosphamide, along with total body irradiation. So these are the most important culprits in development of mucositis in context of the bone marrow transplant patients. How do we grade mucositis? So this again, I think that most of us are quite familiar with. So there is the WHO oral toxicity scale. There are also various other scales, but more or less the grading is almost similar. So the grade 1 is soreness plus minus erythema. Grade 2 is erythema plus ulcers, but patient can swallow solid food. Grade 3 is when the patient, so there is ulcers with extensive erythema, patient cannot swallow food and is mainly on the just liquid diets. And grade 4 is mucositis to the extent that elimination is not possible, and sometimes even the patients require intubation and respiratory support if the respiratory mucosa is involved, or if the airway is getting compromised because of the extensive swelling of the mucosa. So this is about the grading of the mucosa. Now, before I go into the treatment per se, just a brief about pathophysiology of oral mucositis. So this is important to understand, because when we talk about various therapeutic agents, there are some agents which act at different steps of pathophysiology of the disease. So first step is the initiation step, which could be because of radiation plus minus chemotherapy, which induces basically cellular damage, and the reactive oxygen species are formed, which could be going and damaging both the basal epithelium as well as the submucosal cells. The mucosa as such is intact and grossly normal during this stage. So once the initiation phase is done, then comes the stage of primary damage response. So in the phase of primary damage response, there is cellular damage, the P53 is activated and the NF-kappa B is activated. So in the pathophysiology of mucositis, these two factors play important role. And this is actually responsible for the propagation of the damage response, which I'll be describing subsequently. So first step is cellular damage, ROS is generated. Second step, the P53 and NF-kappa beta is activated. And third stage is basically mediated by the cytokine response. So the cytokine response is, so once the NF-kappa beta activation is done, the various inflammatory cytokines come into place, including TNF-alpha, IL-6, interleukin-1 beta, and this ultimately leads to tissue damage and cell death. Okay, so during this stage also the mucositis may be subclinical or just maybe starting to onset. The fourth phase is the phase of ulceration, which is the phase of active cell damage, active ulceration. There is gross erythema, the patient is finding difficult to swallow. So during this stage, there is high risk of bacterial colonization. So whenever this there is grade 3 or grade 4 mucositis, we put the patient on prophylactic antibiotic, because as we all know that mucosa forms important cellular defense barrier to the infections. But because of damage of mucosa, there is high risk of bacterial colonization, bacterial translocation, and bloodstream infection. So we need to put the patients on antibiotics for prevention of such sepsis. And the last stage is obviously healing. So healing occurs once there is cessation from the ongoing tissue damage and that initiated the mucositis. So this was about the various stages of mucositis. Now, what could be the various patient risk factors? So this I'll be describing subsequently, but so there are various factors which have been linked into. For example, I've already mentioned there are certain chemotherapy agents, for example, high-dose melphalan, high-dose busulfan, cyclophosphamide, plus-minus radiation. So these are associated with higher degree of mucositis. Dose, frequency, and duration of treatment, as I was just mentioning, those conditioning regimens which there is reduced intensity conditioning, non-myeloablative conditioning, the incidence of mucositis is quite low. Smoking, poor oral hygiene, again, as I showed that these are all have been associated, but none of them very conclusively shown significant association. Younger age, female status, pre-treatment nutritional status, and pre-treatment neutrophil counts. So all these have been important factors associated with development of mucositis. So what about the preventive measures that we can take? So oral hygiene is very important. So for example, brushing with the sharp toothbrush twice daily, early professional dental assessment prior to the patients who are at high risk of developing mucositis, aggressive prophylactic dental care, cryotherapy or ice chip therapy. So just very simple thing, patient hold the ice chips in their mouth 30 minutes before the giving high-dose chemotherapy, for example, fluorouracil or specifically high-dose melphalan. Mucoadhesive hydrogel rinse and calcium superphosphate rinses can prevent mucositis. I'll be going into the evidence of each of these agents subsequently. Again, prophylactic measures for radiation in mucositis, almost same. So prophylactic dietary modifications like avoiding food which has got high sugar content, acidic or sharp foods. Use of honey, especially in children, has been shown to be a beneficial. Swish and spit before the administration of radiation. Mucoadhesive hydrogel rinses, calcium phosphate rinses. Low-level laser therapy has also been used in prevention of radiation-induced mucositis. And in patients who are at very high risk of mucositis, but we need to give them high-dose chemo plus minus radiation therapy. So often, I mean, this is not done prophylactically, but in most of the situations, but so we could resort to extreme measures, for example, percutaneous endoscopic gastrostomy tube in patients who are at high risk of mucositis and to prevent the onset of dehydration or weight loss. So moving now on to latest clinical guidelines and studies for management of mucositis in BMT patients. So this is what I'm mentioning, oral cryotherapy in prevention of oral mucositis with cancer chemotherapy. So just going into the conclusion. So in this study, they have shown that oral cryotherapy is quite effective in preventing of oral mucositis in BMT patients. So again, in this study, they had seen into a survey by Eastern Mediterranean BMT group. So they had seen practice of oral care for bone marrow transplant patients. They had seen, they had used various modalities, for example, soda bicarb rinses, chlorhexidine gluconate rinses, in addition to ice chips for dry mouth. And they had graded the mucositis using the WHO scale or visual analog scale for pain. And they had seen that mucositis was well managed with lidocaine solution, magic mouthwash, and systemic pain medications as well. So another study showing certain efficacy of honey and photobiomodulation therapy in patient population with like pediatric cancer patients who are at developing high-grade oral mucositis. So now coming to the JCO practice guidelines. So for assessment of risk of mucositis, so basically summarizing like almost whatever I've discussed so far. So there are certain patient factors, for example, smoking, basic oral hygiene, age of the patient, female sex, pre-treatment nutritional factors. So these are basically patient factors related to development of oral mucositis. Now there are disease-related factors. For example, if the patient is having head and neck cancer, if whether the patient is having chemo along with radiotherapy, planned duration of treatment, dose of therapy, and frequency of therapy. So all these are significant risk factors for development of mucositis. And for prevention of mucositis, so if the patient is receiving chemotherapy, we could go ahead with prophylactic oral care, professional dental assessment, cryotherapy, mucoadhesive hydrogel rinses, and supersaturated calcium phosphate rinses. So all of these agents could be used in combination or alone if the patient is at high risk of developing oral mucositis following chemotherapy. What about radiation therapy? Almost similar. So again, professional dental assessment, appropriate shielding and limiting of the mucosal exposure, various dietary modifications that I've already mentioned. For example, avoiding of high starchy and acidic food, avoiding of sharp food, mucoadhesive hydrogel rinses again, and supersaturated calcium phosphate rinses. Benzodiazepine mouthwash has been shown to be quite effective. This I'll be covering subsequently. And some people have even used low-level laser therapy. So again, now coming to the management part. So this is about the the risk factors and the preventive part. Now coming to the management part per se. So we need to assess the severity of mucositis by level of pain, amount of oral intake, oral bleeding, history of fever. In the examination, we need to look into various factors, for example, signs of secondary infection, the risk of hypovolemia, and a complete systemic physical examination, basic biochemistry and the complete blood count, and grading as per the CTCA NCI guideline or the WHO grading scale. If the patient is having grade 3 or grade 4 antibiotics, so often these patients require hospital admission for management of pain, for management of IV fluids, and as well as for sepsis management. What about the treatment? The treatment again depends on whether the patient has got mucositis post-chemotherapy or post-radiotherapy. There are certain agents which are common to both guidelines. For example, bland rinses using just normal saline or soda bicarb rinses. Lignocaine viscous rinses, so again, suicide fit, this is again available commercially, quite effective in relieving the oral pain. Diet modification to just go into semi-solid or liquid diet. Morphine mouthwash has been shown to be effective, and systemic opioids for management of the pain. So pain management forms a cornerstone of managing mucositis. It is, the best pain management with the systemic opioids can be given by patient-controlled analgesia. And if this is available, we should always encourage to going for patient-controlled analgesia, because the patient also gets a physical, feeling of psychological independence when they're using PCI, and it's quite effective in management of pain. For radiation-induced mucositis, again, various agents have been used: carbapenem, low-level laser therapy, 2% morphine mouthwash, doxepin-containing mouthwash, and as well as systemic opioids. So these are the agents that we use most commonly. There are certain other targeted agents. For example, dexamethasone mouthwash could be used for everolimus-induced mucositis, systemic steroids for refractory mTOR inhibitor mucositis.
Sir, you have 1 minute to compile, sir.
Yes, so I'll just conclude quickly. So these are just some of the evidence-based guidelines. As you can see, wide agents have been used: amifostine, supersaturated calcium phosphate, cryotherapy, chlorhexidine mouthwash, glutamine, GM-CSF, oral hygiene, histamine, misoprostol, and so on. So just to conclude, so basically there are other agents which have been used. For example, the tralifermin have been used, low-level laser therapy, morphine, and this part I think I've already covered. So basically oral care protocol, cryotherapy, opioid analgesics, and different types of mouthwashes. There are certain agents which are not of any benefit. For example, antimicrobial mouthwash, IV glutamine, not much of any benefit. GM-CSF was used initially, but most of them have not shown any significant benefit in prevention of oral mucositis. Similarly, with oral pentoxifylline and systemic pilocarpine as well. Benzodiazepine mouthwash is one other such agent which has been shown quite effective in prevention and treatment of oral mucositis. And again, how does it act? Basically, it acts by inhibiting the activity and production of several pro-inflammatory cytokines, thereby preventing the incidence of ulceration. So coming to the conclusion, so the patient should be closely monitored throughout the hospitalization during the bone marrow transplant. Oral examination should be performed daily along with general examination. Severity of oral mucositis should be graded as per the WHO scale, and whenever the patient is detected to have oral mucositis, local anesthetic and anti-inflammatory solutions should be applied on the damaged mucosa. In case of grade 3 or 4 oral lymphocytics, the patient should be admitted, started on systemic analgesics with morphine or any other opioid, and proper care should be taken to be the patient's nutritional status as well as prevention of infections. In grade 4 mucositis, often the patient needs to be put on TPN or tube feeding. With that, I'd like to thank you all, and once again, I'd like to thank Dr. Ankur and the organizers for giving me this opportunity.
Thank you, Dr. Dipanjan, and it's really nice and elaborative presentation. We know the mucositis sometimes seems it's nothing but in BMT patients that can cause major problems and infections too once the mucosal barrier is not broken. We have 1 to 2 minutes. If in case any queries or any questionnaires are there, we can discuss regarding the mucositis with sir is there. And anyone means they can put the messages in the chat box or in the queries if any panelists want to discuss anything or any delegates. Okay, so if none questionnaires are there, we can shift to the next session. So the next session is sponsored by Pfizer, and Dr. Isha Kaul she's the speaker. So she's a senior consultant senior consultant with the Department of Hemato-Oncology and BMT at Max Hospital, Vaishali. She'll talk on what's new in the treatment management of relapsed refractory adult ALL. Over to you, ma'am. So the rice is yours. You can proceed with that.
Thank you, Dr. Ankur, and thank you to all the organizers of this team for organizing this meeting and for giving me this opportunity. So I'll be sharing my screen now. Please let me know if my audio and video are okay.
Yeah, ma'am. You are audible, ma'am. So yeah, we can see the screen, ma'am.
You can see my slides. Okay. So the topic that I'm talking about today is the updates in the management of relapsed refractory ALL in adults. So this data that basically the outcomes of acute leukemia, acute lymphoblastic leukemia in the relapse setting in adults is extremely dismal. And we all know about it. This is no surprise. Even from the ECOG study and all large such studies, it has been shown that outcomes after first relapse are to the tune of less than 10%. Sometimes when we talk to our patients, we say 20-30%, but in our hearts, we know that it's actually very, very dismal. And this data is, of course, around 20 years or so old, where the options for salvage therapy were very limited. But relapsed acute leukemia for any hemato-oncologist is one of the most challenging and dreaded situations. Within that subset, if the disease is fundamentally more sensitive, that really impacts the survival. If at the time of relapse the disease is resistant and is not able to achieve remission, then that is pretty much a death sentence for the patient. The response rates, these are just data from a number of studies showing response rates to standard salvage chemotherapies before the era of the current novel treatments that are available. And as you can see, the responses range somewhere in the 10 to 30% range. So only about 1/3 of patients are even able to go into remission. And when they don't go into remission, the survival is of course poor. So this is international data. We don't have a lot of data from India about this population, but whatever little we know, that adult ALL forms a substantial portion of our practice in hematology oncology. The treatment, it's all multi-agent chemotherapy, whether it is a BFM-like protocol, GMOL, Sometimes TKI is included if it is pH positive and hyper CVAD. So these COG, so these are the standard protocols that most people are following in different centers across India. The remission rates are in the tune of 50, 60, 70%, depending on the age. In the younger adult population, the AYA population, it's more towards 70, 80%. But as we go older, in the 40s and 50s, we know that remission rates are lower. Whether it is the nature of the disease itself, or whether it is the inability of these patients to tolerate multi-modality, multi-agent therapy, is still up for debate. So the remission rates and the relapse rates are somewhere in the 40-50% range. So what do we do when these patients relapse? This data which is published by Dr. Radhakrishnan, it shows that a lot of patients end up getting palliation. Perhaps because they are not fit, or financially, the finances and fitness are generally the two challenges that we faced. So one can speculate that those are the reasons why curative therapy is not given to these patients when they relapse. So now we are living in a different era. All of this information, as I said, is from the last 2 decades, where all the treatment for ALL was conventional chemotherapy, multi-agent chemotherapy. But within the last 5-10 years, immunotherapy has come into the field of ALL in a big way. There are different targets which have been studied, and different modalities, whether it is CAR T cells, whether it is bispecific BiTE antibodies, or whether it is drug antibody conjugates. So all these different things have brought in a much needed advancement in the field of acute lymphoblastic leukemia. So when we talk about immunotherapy, which is the advancement, what kind of a target would we want if we were to design a drug for ALL? So it should be a target which is expressed on a high percentage of leukemic blasts. It should be a target which is expressed in a high density, and ideally which is not expressed on normal cells to spare a lot of toxicity. So with these ideas in mind, the 3 targets which have been explored is CD20, which is basically normally present on the precursor cells. And the expression is somewhere in the 50% range. Around 50% of adult leukemias will have CD20 expression. CD19, which is a mature B-ALL marker, which is expressed in vast majority of ALLs, and CD22, which is also present in a lot of patients. So today we'll specifically talk about the therapy which is available to us in India, which is inotuzumab ozacamycin. So as we know that this is a drug antibody conjugate in which the CD22 antibody, which is inotuzumab, has a toxin which is conjugated to it. And this is just a diagram to show the molecular structure. So how does this work? CD22, as I just said, is expressed on most patients with B-cell ALL. The inotuzumab, the antibody part, which is the monoclonal antibody against CD22, it binds to the cell surface of the leukemic blasts, and it leads to the internalization of the ozacamycin part, which is the toxin part inside the leukemic cells. It's a very potent tubular toxin. It binds to DNA, it induces DNA breaks, which leads to the apoptosis of the tumor cell. So it is, but it's kind of like targeted therapy, but at the same time, it has features of cytotoxic therapy as well. So drug antibody conjugate mechanism. The other drugs such as gemtuzumab, Milotag is another example of similar principle, and brentuximab vedotin is also works on similar principles. So inotuzumab has been studied for about the last decade at different dosing formulations, and the big study which led to its approval was, of course, the Innovate trial, So the study started in 2014, and this slide is basically just showing a quick timeline of how the study came into being. Finally the interim data was published in the New England Journal of Medicine in 2016, and long-term analysis was published in 2019. So here is the study design of the INNOVATE trial. So all adult more than 18 were eligible, relapsed refractory CD22 positive ALL. It had to be either salvage 1 or salvage 2. And the Philadelphia chromosome positivity did not influence the eligibility for the study. The primary endpoints were CR or CR with incomplete count recovery and overall survival. And then there were a number of other secondary endpoints. It was a total number of 326 patients were enrolled on the study, and they were stratified based on the duration of the first remission, whether it was less than or more than 1 year, whether it was salvage 1 or 2, and the age, whether it was less than 55 or more than 55. So those were the stratifications within the study. The standard of care control arm either had FLAG, cytarabine plus mitoxantrone, or HiDAC as the standard of care conventional chemotherapy options, which were available. And on the inotuzumab, this was single agent inotuzumab. The starting dose was 1.8 milligram per meter square per cycle, which is divided into day 1, 8, and 15. So on day 1, you get 0.8 milligram per meter square, and subsequently on the 8th and 15th day, you get 0.5 milligram per meter square, for a total of 1.8 milligram per meter square in the first cycle. And after CR, you continue to get 0.5 milligram per meter square in cycle 2 and onwards. So this is just, to outline the distribution of patients on both arms. As you can see that about 2/3 patients were less than 55 years, and about 1/3 were over 55 years of age. And the salvage status for majority of patients, this was salvage 1, and about 30-40% patients, this was the second salvage that they were receiving. And whether the duration of remission at baseline was less than or more than 1 year was around equally split. This, I think, is very important to highlight, that 70% of patients had more than 50% blasts at presentation. This data is important when comparing inotuzumab to blinatumomab, because we know that the activity of inotuzumab is independent of the blast count at presentation, whereas blinatumomab seems to work better in patients in whom the volume of disease is low at the time of giving blina. So in a patient with a large blast percentage, if you are in a situation where you are able to choose both, inotuzumab might, statistically has better chances of putting that patient into remission, because in this study, majority of patients had a very high burden of disease at the time of study enrollment. Now coming to the results. So I think this one slide basically really summarizes how effective the drug is. You can look at the standard of care control arm. The remission rates, the CR rates, are in the tune of what we would expect, around 30%, which is something that we've all come to accept as the CR rate in a relapsed ALL. Just look at the inotuzumab arm. We are seeing CR rates of 80%. I think we could have never imagined even 15 years back that we would have a situation in which we'll be able to put 80% of relapsed B-ALL into remission. That's pretty outstanding. And also most of these CRs actually also had MRD negativity. So these patients are not just going into CR. A lot of them are experiencing MRD negative, so very good quality remissions. So the difference between standard of care conventional chemotherapy and inotuzumab was very marked. It was not subtle. And like I just pointed out, even for patients who had more than 50% blasts at baseline, the CR rate was still pretty high at about 78%. This is pretty much the same thing. Now talking about, when, a lot of times this question comes that how long will it take for the patient to go into CR? Majority of patients who had a good response did so within the first cycle. So 70% of patients achieved CR within the first cycle. And after, another 25% achieved remission after the second cycle. So, and for patients who did not enter remission after 2 rounds of inotuzumab, 2 cycles of inotuzumab, are unlikely to benefit from anymore. So pretty much the first cycle gives you a very, you can predict whether a patient is going to benefit or not after 1 course of therapy. And for about maybe 25% of patients, they could benefit from 1 more round to see if they are going into remission. But if 2 cycles are not doing it, then further treatment is unlikely to add any more benefit. This is again, summarizing the same kinetics. That additional cycles beyond cycle 2 are unlikely to add more value to put patients into remission. If the patient is going to go into remission, you will know that in the first cycle and at max by second cycle. Progression-free survival is 1.8 months for, is around 5 months for the inotuzumab arm as compared to 1.8 months. But I'm not sure in the situation of malignancy in which either you cure it or, this is not a solid malignancy where you are palliating these people for very long, what progression-free survival means, because as I will show you in the next few slides, unless these patients go on to receive an allogeneic stem cell transplant, the benefit from the initial remission becomes pointless. So the idea, so as you can see, for patients who received inotuzumab, about 70 to 80% of them were able to go to a transplant. So as opposed to the standard of care arm, where only about 35% patients were able to go to transplant. So the goal of salvage therapy, inotuzumab-based salvage therapy, is basically to take these patients to make them eligible for the benefit of allogeneic stem cell transplant, which is the modality which will ultimately is the best bet for the long-term survival. So long-term survival is 23% on the inotuzumab arm versus 10% on the standard of care arm, which largely depends on how they did on transplant. So which patients are the ones who are likely to survive the longest? This is pretty predictable that baseline MRD status, if they are MRD negative, that predicts for better outcomes. The hazard ratio is 1.99, so that's significant. And the second is the ability to get a transplant. If a patient is not able to get a transplant for financial, logistic, and does not have a match, is not fitness, for any of those reasons, they do poorly. Whereas patients who are able to go to transplant, they do significantly better. Now coming to toxicities on inotuzumab versus standard of care, that's actually something also very amazing about these new age drugs, is that toxicities which, when we think about salvage chemotherapy for relapsed leukemia, we think very, very harsh therapies, prolonged neutropenia, infections, fungal infections, gram-negative sepsis, severe mucositis. So all of this becomes less of a challenge with inotuzumab because extra hematological toxicity is very minimal, and even hematological toxicity is less. If you see here that febrile neutropenia rates are 27%, so almost half of that with the standard of care. So myelosuppression is very minimal. The need for hospitalization, the total number of days that one has to spend in the hospital is less because it can be administered mostly on a daycare basis. The challenge, which is the unique challenge with inotuzumab, is hepatotoxicity. And the development of veno-occlusive disease during treatment with inotuzumab, and especially during a subsequent stem cell transplant, is the main sort of issue that has to be fine-tuned for best outcomes out of the inotuzumab. Like I already said, the total duration of hospitalization, need for hospitalization is much less with inotuzumab. Febrile neutropenia is much less with inotuzumab as compared to HIDAC or FLAG or mitoxantrone-based therapies. Burden of hospitalization. Right. So I'll talk about VOD again in a little bit. But on this slide, I think the one thing that I want to highlight is who are the patients who do well on transplant. So the two things which seem to matter the most is whether the patients directly proceed to transplant or after their salvage, if it's their first salvage or if it's their second salvage. And the patients who proceed directly to transplant after first salvage do better. So here the 24-month survival is 45.8%. And if they do after 72, then the benefit goes down a little bit. So I think the message that one takes from there is that if we are considering inotuzumab for a patient, it is better to use it as soon as they relapse. Because that gives them the most benefit out of taking the drug. If we wait for another relapse, then the benefit goes down with every subsequent line of therapy. And for patients who do not proceed to transplant, the survival is very dismal. So that goes on to emphasize that the therapies are basically in this scenario a bridge to transplant, and by themselves are unlikely to give long-term overall survival. So the message is that it should be used early as an earlier salvage, and for most benefit, it should be consolidated by an allogeneic stem cell transplant whenever possible. MRD status, like in all ALL, is also important here. Patients who are in MRD negative remission and they go on to transplant do better. So two things which matter is the line of salvage, whether it's given earlier, and MRD negative status. The disease burden, the blast percentage does not seem to matter as much. Like you can see, and this is stratified the CR by the percentage of bone marrow blasts, whether it is less than 50, 50 to 90, or more than 90%. So irrespective of what the baseline blast percentage is, the CR rates are upwards of 70%. So that is one thing that this matters a lot in blinatumomab, but does not seem to make that much of a difference when it comes to inotuzumab. What about the CD2 expression level? Does it matter how strongly it is expressed? So here, it's been separated out by quartiles, and the stronger the CD22 expression, it does seem to give some additional benefit, but it's not that important. So any level of CD22 positivity, here it's split by more than 90 or less than 90%. So even in patients with less than 90%, the benefit, the CR rate is to the tune of 60%, which is still better than standard of care response. So definitely patients with very strong CD22 expression are likely to benefit more and will have a higher rate of CR. But even patients who have a lower expression, even in those patients, the benefit is still better than standard of care, though the difference then is less marked as in the other group. What about patients with pH positive ALL? Even in those patients, incorporating inotuzumab, the response rates are higher, and they also benefit from inotuzumab based salvage. So this is all data based on the approved dosing regimen of inotuzumab, which is single agent inotuzumab. There are smaller studies of using inotuzumab in combination with conventional chemotherapy. We, in our practice, have incorporated that, and that is what we are using in a majority of our patients whenever we are incorporating inotuzumab. This is, of course, off-label, so I'll put a disclaimer to that statement. We published our experience in this regard in last year's HEMATOCON, where the inotuzumab is used in combination with the hyper CVD-like protocol, in combination with rituximab if CD20 is also positive. It's a mini hyper CVD inotuzumab, basically. The advantages in this regimen is that the CR rates are high. There's an MD Anderson reference that we used for to design our protocol for our center. So the advantage is that the total number of inotuzumab that you are using, the total dose of inotuzumab that you're using is less, because the dosing in this is 0.6 milligram per meter square on the first dose, and then a amount of inotuzumab exposure prior to transplant also influences the risk of development of VOD. So if we are able to limit that amount to less than 1.8 and within 1.5 milligram per meter square, that has been shown to decrease the risk of VOD toxicity during transplant. So that's been our experience of using it in combination along with conventional chemotherapy, albeit at lower doses. So the cyclophosphamide, vincristine, and dexamethasone dosing is less than conventional hyper CVAD, and we have had good experience in the combination setting as well in the mini hyper CVD protocol, and that's what we are using instead of using single agent inotuzumab. So as I have already said previously, the goal eventually is to take these patients to transplant, and the advantage is that it makes around 70 to 80% of patients transplant eligible by putting them into remission. And patients who go are transplanted have a longer survival. That has already been stated. So the greater
another 2 minutes to compile.
Yes. So the greater the number of inotuzumab cycles before, the higher the chances of transplant-related mortality. That's very important. VOD is the single most dangerous thing. And what can we do to decrease the chances of VOD? One, try to limit the total amount of inotuzumab before transplant. Second, there needs to be a washout period of at least 3 to 4 weeks, and you can bridge it depending on with something conventional therapy, even Christian Dexa, but there needs to be a washout period before transplant. Using Utiliv seems to be helpful, and avoiding azoles is also something that is helpful. So in these patients in conditioning or the standard transplant prophylaxis, if you're using azoles, we are using either anidulafungin, caspofungin, or amphotericin, depending on the previous risk profile of the patient, instead of azoles when we are taking them for transplant. And avoiding dual alkylators, so bucci, thiotepa, those kinds of conditioning regimens, which are traditionally more likely to cause VOD, should be avoided. So single alkylator is probably okay. So something like flu TBI or flu bu is better than bucci or thiotepa for the risk of VOD, which is the most significant risk. So just to summarize that there is no doubt about the fact that inotuzumab is superior to standard of care in terms of inducing remissions. Definitely this needs to be consolidated with transplant with an adequate washout period in which some amount of bridging therapy, which is inotuzumab free, needs to be used. I think it is just gaining more experience with using it to get comfortable to plan the whole treatment protocol. Instead of what conditioning regimen to choose, instead of using dual alkylator based therapy, incorporating TBI, fludarabine might be better for VOD risk. And just a limited experience from our own setting of using it in combination with the hyper CVD like protocol to decrease for cost saving, as well as limiting the total exposure of inotuzumab before transplant. So I think that's pretty much, these are just, other smaller studies which are emphasizing the same things. I think with that, I'll conclude my talk and leave it open for any questions. Back to the organizers.
Thank you, ma'am. Sometimes I really think that having these targeted molecules and soon the treatment regimens will change, as rituximab has changed lymphomas, maybe this inotuzumab will change ALL.
Yeah.
I do wonder, thinking that using this molecule in old patients as frontline instead of chemotherapy regimens, or we have limited baskets in Indian scenario using hyper-CVAD and other GMAL protocols are toxic for old patients. Soon we may have data in the old patients and it get approved as first line to be used. Maybe that helps us a lot.
No, I completely agree with you, because the drugs which are traditionally effective, like vincristine, high dose of asparaginase, and high dose steroids, are extremely poorly tolerated in the older people. So in those patients, using tuzumab based therapy upfront makes logical sense, and hopefully with more stronger data we'll be able to do that.
Yeah. So any questions or any queries? So the session is open for the discussion. If none, then we can switch to the next session. Ma'am, you have explained well, so we can switch to the next session. This session is sponsored by BART. So I welcome Dr. Sachin Yadav. He's a group head of hematology and stem cell transplant at HCG Network, Bangalore. Sir has a dynamic personality, and sir will speak on picking up the right venous access in the cancer patients. This is a really great topic in the patient, so we can understand having a single prick for the sampling, and the hematology patients to have to undergo repeated pricks for the sampling is really a nightmare. Over to you, sir.
Thank you, Ankur, and thank you, BD, for supporting this talk. Organizers for giving the opportunity. I'll be talking about something that has actually been very close to my heart, and primarily because no matter what kind of chemo we do or how good we are in transplantation, the most important cause of mortality in our patients is infections. And more often than not, these infections are passed on to the patient through some few common paths, starting from the gut microbiota to which cause mostly perianal infections or neutropenic colitis, to UTI, respiratory infections which are transmitted through the air. But most importantly, it is the infections which pass through the skin, and this happens because the skin is breached by repeated injections. Because of that, it kind of makes sense to have one single venous access, whereby we can give medicines, chemotherapy, antibiotics, IV fluids, as well as take blood samples, thus avoiding the need to cause repeated punctures and essentially holes in the skin, through which bacteria from the skin surface as well as the environment in the hospital and at home cross over into the bloodstream. What we have done over the last few years is try to see how we can learn to use PICC lines better, and what are the guidelines and how it actually helps us. We also need to understand what are the current practices in our country, and how do we get better every year. So like I said, venous access may seem something small, and most of our patients actually do not complain if they have to get repeated pricks or getting blood sampling or injections. But this really affects the way a patient gets appropriate treatment. And we need to figure out an Indian algorithm on how to use PICC lines in our patients who are getting treatment for malignancies. Yes, we are all lacking in in-depth awareness, mostly because we are so fixated on drugs, right, on chemotherapy and chemo or transplant complications, that the literature, the evidence pertaining to venous access quite often falls outside the field of vision. Thus, we also many times overlook the fact that maybe our team needs training and initial training, ongoing training, and all of this can lead to significant complications. One approach which is being increasingly used across the world is having a VAT, that is venous access team. And what VAT does is you know, it, you kind of designate a small bunch of people who will do venous access management, both insertion as well as ongoing care. And since you can then kind of consolidate the knowledge in a small group of people, they are able to manage the PICC lines better. Your complications during insertion as well as during maintenance are significantly reduced. We started exploring this approach of creating a venous access team a few years ago, and now I think we have achieved some success in that. So let's see where you know, this talk takes us, and whether we can kind of come to a consensus about the different types of central venous access and what is appropriate in our country, considering the issues of cost, considering the issues of literacy, right, and the problems that we do not really have good primary and secondary care in our country. So, we may treat the patient and put in a particular central venous access, but once treatment is over, they'll be going back to the community. So, we all are aware that we don't have good support from community physicians, well-trained community physicians, for whom oncology is a very minor part of their practice. So let's start with the kind of drugs that we use. And this slide kind of mentions that most of the chemotherapy drugs that we use are quite toxic. And when they lead to extravasation, and mind you, at least 1 in 5 patients will have some extravasation if we use peripheral venous access. So when there is extravasation, there will be problems. And even when there is no extravasation, there is irritant thrombophlebitis, which can happen in the peripheral vein if we use peripheral venous access. All of us are aware of this, but the magnitude of the problem is quite surprising when we first hear about this. Now, leaving aside the complications caused by chemotherapy, we need to understand that the different kind of venous access devices have different utilities. We cannot use peripheral IV cannula, whether it's inserted blindly or ultrasound guided or infrared guided. We cannot use them typically for more than 5 to 7 days. And all of us are aware that usually within 2 to 3 days, the patient starts having problems when we use peripheral IV cannula. So either there is, extravasation or pain when an injection is given. So these are essentially peripheral IV cannula, or for short-term use, typically less than 5 to 7 days. And we use these in our practice in the outpatient or daycare clinic. But when we use peripheral IV cannula in the ward for patients who are going to require treatment, especially supportive care for neutropenia, for an extended period, right? Most of the patients who undergo treatment for AML or ALL chemotherapy will be in the hospital for a few weeks. Now, the practice in an intensive care unit is pretty different. That's the time when the patient goes into the ICU for a critical condition, and they want very rapid IV access. They do not want to, the intensivist typically does not want to, use a small caliber vessel as in a peripheral IV cannula. They don't want to spend time doing ultrasound guided insertion of a peripherally inserted central venous cannula. So they go for midline catheters. They'll typically go for internal jugular or an external jugular, or even a subclavian catheter insertion. And these are essentially acute central venous catheters, where the aim of venous access is to get a quick access to high flow, large caliber vein to give rapid intensive care. Now, our patients are in the third category. These do not require typically instant urgent care. We have the time to put a PICC line, that is a peripherally inserted central catheter, We even have the time to put in a tunneled catheter like a Hickman catheter or a portacath. So these are patients where we are typically planning treatment, and we have a few hours to maybe a day or two to get the ideal venous access for our patients. Now, these two tables tell us what is appropriate, what is neutral, and what is inappropriate. For example, if we want to just give treatment for 1 to 2 weeks, then a PIC can be inserted. We often use PICs in patients who are going to be in the ward just for a week or two, for supportive care, because that truly gives us a very nice central venous access. However, at this point in time where you only are going to give treatment for maybe 2 to 4 weeks, a portacath, which requires a surgical exercise, may not be at the right approach, right? And this is for medicines which are given, and this table kind of tells us what about the blood sampling. So typically patients who are admitted for leukemia treatment require blood sampling at least once a day, right? We do CBC, we do electrolytes, and so most of our patients with leukemia get a PICC line. Nowadays, we are moving away from Hickman line catheter, and in our practice, we use Hickman lines only for small babies because it's quite often difficult to maintain a PICC line. They pull it out, and these are not secured in the subcutaneous space. Hence, we use PICC lines for almost all of our patients except small babies up to say 3 to 4 years old, where we use a tunneled catheter such as a Hickman line. We do not use portacath in our practice, although many oncologists do that, and it's perfectly fine. But portacath as a means of venous access for blood sampling is not a good idea, because ultimately you have to poke it with an access device. But it's absolutely fine to give chemo even in several hematologic malignancies. So a lot truly depends on the experience of the team, the expertise, and the comfort of the team. But it's fair to say that if you want to give treatment for less than a week for patients who are not likely to be sick, so for example, milder chemotherapy like R-CHOP or ABBD, you are absolutely fine to go ahead with the peripheral venous access. But anything more intense than that requires some kind of central venous access, and whether to use a PICC or a Hickman or a port truly depends on you to give medicines. In our practice, we found that PICC lines are the most user and patient friendly. So we also need to think as to what percentage of our patients are going to use short infusions or long infusions. And this slide kind of mentions the infusions pertaining to with respect to the chemotherapy. But in my mind, it is the supportive care which is more important, because chemo is given once or depending on the regimen, multiple times in a month. But on a daily basis, the patients need IV fluids, and especially in the first week or so, when we are expecting tumor lysis syndromes, our patients need continuous IV fluids. They need support for electrolyte imbalance, right? Most of our patients either have imbalance with potassium or magnesium. You're worried about creatinine. So of course, depending on the duration of the chemo infusate or the supportive care medications, including IV fluids, we again tend to decide what type of venous access we are going to use. Like I had said earlier, almost every chemo agent is toxic. And it's toxic because it's a concentrate of a chemical, right? It's a concentrate of a chemical which is given IV more often than not. And this concentrate can damage the vascular endothelium. And this damaged vascular endothelium not only is painful and leads to phlebothrombosis or even deep vein thrombosis, but it also can lead to being a nidus of infection. So that's one aspect. And thus we ourselves consider that every chemotherapy agent is potentially a vesicant or an irritant, and to prevent extravasation and thrombophlebitis, to prevent frequent pricks on the skin, which not only are uncomfortable but can be a source of bloodstream infection. We prefer central venous access devices for all chemotherapies except those for lymphoma or myeloma, which are very short duration and infrequent chemotherapies. So we use CVADs for all leukemias. In lymphomas, we only use it for those patients who are getting more intense chemo, such as hyper CVAD. Otherwise we do not use it. And this is the typical timeline of our patient, right? The hematologic malignancy is confirmed. We give first-line chemo, which can be as short as 4 cycles, could be as long as 1 year, as in the GMOL 0703 protocol for ALL, and the patient gets better or moves on to more treatment, as in a stem cell transplant, and many patients get cured. But some don't, and then they come back for second-line chemotherapy, and then third line, etc. And not only are the second and third line, but this could be the second phase or the third phase of chemotherapy, moving on to maintenance. So throughout this duration, we can have central venous access, either in the form of a PICC line or a Hickman or a Portacath. Like I said, we tend to use PICC line, and the real question is whether a PICC line can be kept on for so long, whether a PICC line can be maintained for more than 3 months, 6 months, or even a year, or will most of the patients get complications and you have to reinsert another PICC line. So for that, what we have seen is if you actually have a well-trained team which focuses on nothing but central venous access, in many of our patients, PICC lines can be maintained for over a year. And there are very few patients really in whom we have to remove them earlier, mainly because of bloodstream, catheter-related bloodstream infection. And for that, we follow the IDSA guidelines, which I think were last updated in 2009. But there is a newer version specifically for CRBSI, catheter-related bloodstream infection, that tells us that in what kind of infection you really need to change your central venous access. Now, other than infections, we have hardly seen any other complications with PICC lines. Deep vein thrombosis is probably the next common complication, but I haven't seen a fracture of a line in many, many years, which goes on to say that most of the PICC lines which are manufactured today are very robust. And this experience that we have is, of course, based on and backed up by, the recommendations of various organizations, starting from ASCO, the guidelines given by MD Anderson, as well as what is recommended and practiced in NHS UK. So yes, you can use a PICC line for long periods of time. And I think the longest that we have had is about 18 months. After that, we removed the PICC line because it was no more required. So putting all this together, we need to think as to what is our practice. Do we have a dedicated PICC line team? And this is where I would like to ask Dr. Ankur as to what is the practice in his center.
Sir, at my centers, usually the PICC line insertions are done by me only. We don't have the trained team, but we trained our staff to how to handle the PICC lines. Yeah. And with due time, I'm training my staff to help me out for the insertions also. And I have one, this is the anesthetic team, the doctor with me, so in case the access is difficult, we use ultrasound guided PICC lines with them.
Yeah. That's a, and all of us start like this, Ankur, but I'm sure as you get busier, you'll start thinking as to whom do I delegate this to. Yeah. And quite often we are worried about, handing over such a vital exercise to our nurses. But, in our center for several years now, there's a nurse practitioner who's been inserting PICC lines. And if I'm not mistaken, he's done over 1,500 PICC insertions. And we regularly audit the data, and that has been published as well. And that shows that the risk of complications is equal. All that matters is somebody does it on a regular basis. Could be a doctor, could be a nurse. We use ultrasound guided PICC placement, but I understand that there is a challenge in the cost of the ultrasound equipment. But if you can get it and get your team trained, that really works very well. A lot of education for the patient and the caregiver goes into ensuring that they take care of the PICC line, that it doesn't get soiled, the dressings don't get wet, especially when the patient has a bath or uses the washroom. And not only the vascular access team, but the entire nursing team needs to be trained initially as well as on an ongoing basis to ensure that they handle the PICC lines properly. If our nurses do not use sterile gloving technique, if they do not use hand washing as per the WHO guidelines, then sooner or later we are going to end up, creating a catheter-related bloodstream infection. And of course, it goes without saying that nurse-led PICC insertion is cost-effective. It reduces the cost of insertion. The insertion rates are very good if a dedicated team does it, and the complication rates are also pretty acceptable. And this is where there are good papers, including the one present, including the two published from our center, which says that if you are able to use ultrasound guided insertion, then all the usual complications actually reduce, making it ultimately cost effective. So yes, there is an increased capex initially in buying the ultrasound machine, but ultimately it turns out cheaper for the patient. I'm really grateful to BD for supporting all of this throughout the years in helping build centers of excellence by virtue of their training and data collection, audit, publication, to ensure that we are really at par with what happens in the developed world. Thank you so much.
Thank you, sir, for sparing the time and for the nice presentation with an elaborative
Pleasure.
and all the experiences. And it's really nice that your center has published 2-3 papers in the PICC line insertions. Any queries or any questionnaires that can be taken up? Here. So then we can. Okay, so then we can move to the next session. Thank you, sir. And now I'll welcome.
Thank you.
Thank you, sir. Now I welcome Dr. Subhash Verma. Sir doesn't need any words, but still it's my duty to introduce the sir. I am really honored that I am assigned this duty to welcome sir. Sir is a very senior personality, and he's a professor emeritus and PGI Chandigarh. Now he's a director of medicine and hematology at Fortis Healthcare Mohali. Sir will chair the next session. Over to you, sir.
Thank you, Ankur, and Emil, for giving me an opportunity to learn from so many people. We had excellent talks in the morning, and now the next talk is by Dr. Meet Kumar, who's a consultant adult hematology and bone marrow transplantation at Fortis Memorial Research Institute, Gurugram. And he's going to tell us about one of the difficult forms of diffuse large B-cell lymphoma. That's a double-hit lymphoma. As to what can we do for these patients. Dr. Meet Kumar, please.
Thank you so much, sir. Yes, sir. So can the organizers please share my screen? Yeah, thanks a lot. Thanks. Thank you so much, sir, for your for chairing this session. And the next slide, please. I want to begin by thanking Dr. Ankur Mittal, who has recently become a very nice colleague, and Like we have recently interacted on many platforms. Thank you so much, Dr. Ankur. And of course, I thank Horizon Conference organizers and of course the scientific partners, especially Dr. Reddy's lab, who has sort of organized and supported this event, at least this session. Next slide, please. So going to the sort of the conundrum of DLBCL or a high-risk lymphoma, high-risk aggressive lymphomas, we have seen over the years, we have all seen that patients with diffuse large B-cell lymphoma, usually we have explained to patients that they have a long-term survival of 60%, 65%, maybe 55 to 65%. But yes, at our own hearts and from the last experiences of couple of years, we know that DLBCLs are not alike. All the DLBCLs are not homogeneously alike. That's a lot of heterogeneity that exists among the subgroup of these lymphomas, these high-grade lymphomas. There is a lot of heterogeneity, and that heterogeneity is the crux to understand what should be our strategies. At one end, when there are good risk high-grade lymphomas, where the long-term survival can be to the tune of maybe 70-75%, at the same site or at the same distant end of the same spectrum, there are such bad high-grade lymphomas, DLBCLs, where the long-term survival will be only to the tune of 20-25%. So if that is a magnitude of difference between the survival amongst a cohort of DLBCL patients, that means that there is something that we are missing, and maybe all DLBCLs or all high-grade lymphomas cannot be categorized under one umbrella. So there is an increasing requirement for us to understand, interpret, and implement that what is that thing that differentiates the different type of DLBCL. The next slide, please. Because what we are interested ultimately is in improving the outcomes of overall all the patients of these high-grade lymphomas. So next slide, please. What ultimately we need is dissecting out that which high-grade lymphomas are going to behave badly and which ones are not going to behave so badly. The next slide, please. So how are we going to identify that which patients can behave distinctly or markedly differently than other patients? Next slide, please. So these are some of the suggestions that have been published over time: advanced stage, higher IPI or revised IPI, classifications based on cell of origin, germinal center versus non-germinal center, the mixed status, be it on IHC or a FISH analysis for MYC. That is what we technically call as double hit and triple hit lymphomas when they are coupled with BCL2 or BCL6, and the presence or absence of CNS involvement. So these are some of the criteria based on we can stratify these patients into whether they are going to behave badly after treatment with upfront chemotherapy or they are not going to behave so badly. The next slide, please. And what are the options that we have that are published that suggest us, okay, this is how we can improve the outcomes of those patients or those high-risk patients that we have identified based on the parameters that we have just discussed in the previous slide. So these are the options that we have. We can intensify the treatment for those ones who have got high-risk parameters, high-risk features of among this cohort of high-grade lymphomas, DLBCLs. We can incorporate novel agents into the upfront treatment regimens for these patients, or we can consider to add some sort of maintenance post after induction chemotherapy with or without consolidation, but we can consider to add maintenance. So step by step in the next 10 minutes or so, I'll just briefly go through the studies and data that is available to us, whether that's a positive data, that's a negative data, that is left to the discussion and sort of interpretation by the delegates. But yes, what data is available, that we will discuss in the next 10 minutes or so. So the next slide, please. The first one is the treatment intensification. What is the data for treatment intensification for the real high risk lymphomas, high risk DLBCLs? Next slide, please. This data analyzed c-MYC positivity, and in those patients who were c-MYC positive by immunohistochemistry, intensification of the treatment to either R epoch versus double intensified or dose intensified therapy by the use of protocol as mentioned in the slides below, that was hypersevad rotating with Codox M. So these were randomized into 3 cohorts for those patients, high-risk DLBCLs who were c-MYC positive. So that was a meta-analysis of close to 400 patients, 11 studies included. And the data showed that for first-line treatment with R epoch that significantly reduced the risk of progression as compared to R-CHOP. However, the overall survival was not statistically different in the favor of R-epoch. PFS benefit in favor of R-epoch. The dose intensified regimen, the outcomes were not so great and not so distinct from R-CHOP, essentially because of the increased toxicities that was seen in these patients. So R-epoch is a regimen that can be considered for patients who have got one of these high risk features to be treated upfront, and R-epoch may be considered. Next slide, please. These are the Kaplan-Meier curves that have suggested that R-epoch may be a better regimen over R-CHOP. And although these data are not statistically significant in terms of overall survival, next slide, please. But these data do suggest the prolongation of progression-free survival with the use of R-epoch based regimen. Next slide, please. Is someone there?
The slides are not moving. Yeah.
Okay. Yeah. The next slide, please. This we have already discussed. So for patients with a higher IPI, can we go straight to R-Codox-M or alternating with IVAC? So that's the hypothesis that was suggested and published in 2018. And what was found was it was in 111 patients, and the outcomes were a 2-year progression-free survival of 67% and a 2-year overall survival of 76%. That was not significantly different from R-CHOP. So there was no comparator R-CHOP arm in this study. But yes, this data showed a non-inferiority for the use of this higher intensity regimen. The next slide, please. And essentially, what could be seen was this protocol of R-Codox-M alternating with EVAC was feasible and effective for younger and fit patients with high-risk DLBCL. So as can be seen in these graphs, for patients who are more than 50 and a PS of higher PS, they really don't do well with this protocol, but others definitely benefit with this protocol because their outcomes are more or less similar. Next slide, please. For patients with a higher stage, can we increase the intensity of treatment from R-CHOP to ARDA-epoch? So this was analyzed in this study published in 2019, close to 525 patients over 8 years. And the significance of this study was that it was a negative study. So for a high-risk patient of DLBCL based only on advanced stage, increasing the dose intensity to ARDA-epoch did not fare significantly better into R-CHOP, either for progression-free survival or and the toxicity was higher in the intensified regimen arm. Next slide, please. The next slide. So can we incorporate certain novel drugs or newer drugs into the treatment armamentarium for treating those high-grade DLBCLs or high-risk lymphomas that will include the double-hit, triple-hit lymphomas? So whether, next slide, please, whether addition of ibrutinib for those patients who have got a non-GCB type DLBCL will help. So this was a Phoenix trial that was published in 2019. And what that showed to us that R-CHOP versus R-CHOP ibrutinib at the dose of 540 milligrams once daily for 6 to 8 cycles coupled with R-CHOP. In this, there were close to 850 patients, and the outcomes were interesting. Younger patients less than 60 years of age had a significantly better EFS, PFS, and OS. That can be seen in the next slides. The Kaplan-Meier curves can show that. So that was a significantly better EFS. The next slide, please. So there was significantly better event-free survival and overall survival when ibrutinib was added to R-CHOP regimen as compared to placebo when added to R-CHOP for those patients with a non-GCB type high-risk DLBCL. And that was a large patient cohort, and that was a statistically significant data in favor of adding ibrutinib for patients with a non-GCB type DLBCL. The next slide, please. The other toxicity profile, the safety profile was definitely more harmful for patients in the ibrutinib cohort, and that essentially affected patients who were elderly. And in those patients, the most common side effects were febrile neutropenia and pneumonias. But yes, there was a separate distinct subgroup analysis that was published later on after 2019 last year, and that showed that ibrutinib essentially worked better in those patients who had a mutated MYD88 and a BCR mutation. So in those cohort, we are not routinely doing MYD88 or BCR mutation analysis for all are patients with DLBCL, but at least, yes, there is some data to suggest that ibrutinib can be added in those patients, and where essentially 79A or B is positive in those patients, essentially the addition of ibrutinib might be helpful. Next slide, please. For those lymphomas or DLBCLs who are CD30 positive, whether addition of brentuximab vedotin to the upfront treatment can be helpful. This was a phase 1-2 cohort study, and that was published in 2020, last year. Brentuximab vedotin added to R-CHP versus R-CHOP for 6 cycles for those patients who were CD30 positive. Not a large number of patients, 31 percentage patients. 8 had diffuse large B-cell lymphoma. The rest of all had primary mediastinal B-cell lymphoma. Interesting was the overall response rate was 100%, although this was upfront and the follow-up data was not very long. The 2-year progression-free survival was 100%, as can be seen in the next slide. Next slide, please. So next slide, one more. The toxicity profile for this cohort, mainly it was hematological toxicity. The cytopenias were the main concern. And in the non-hematological toxicity, the infectious complications was quite significant, followed by thromboembolic events. The next slide, please. So whether addition of polatuzumab can be helpful. So this one is the older study that was published in 2017, and this utilized incorporation of polatuzumab to bendamustine rituximab for relapsed refractory high-risk lymphomas, DLBCLs. 80 patients at this protocol. The overall response rate and complete remission rate was significantly better that we have all seen, and we have tried to counsel patients wherever needed in relapsed refractory patients with DLBCL, and we have seen that addition of polatuzumab very rarely 2 patients experience, but yes, plus minus role, and the data showed median PFS of 6.7 versus 2 months. That can be seen in the next Kaplan-Meier curve. The progression-free survival and overall survival both having a significant benefit in favor of addition of polatuzumab. But that's an older study. The next study is the recent one that is published this year only, and that's a POLARIX data of comparing R-CHOP versus, the next slide, please, of comparing R-CHOP versus polatuzumab R-CHP upfront for newly diagnosed high-risk DLBCL. So this is I could not access the full text of this article. It's published in NEGM recently. There was no full text, at least I could access, but the Kaplan-Meier's are not available. But at least the preliminary data suggested that the progression-free survival is definitely seen for patients who have been receiving the polatuzumab upfront in high-risk DLBCL. Although if we say it was statistically significant data in favor of adding polatuzumab for 76% versus 70% at a median follow-up of 28 months. However, overall survival was not statistically different between the 2 arms. So this is something that we probably will be interested to know and learn more about, although cost limitations will definitely be there. I briefly told like previously, we need to look at the pocket before even suggesting such type of treatments to our patients. The next slide, please. These are a bit of older data, the remodeled trial of incorporating bortezomib to the non-GCB, and that showed there was no difference in PFS in the GCB versus non-GCB. That's an interesting finding. We have generically known that patients who with a non-GCB type DLBCL behave significantly poorly as compared to GCB, but the addition of bortezomib was a benefit. It showed that the outcomes were similar for GCB as well as non-GCB. So there was definitely an improvement in the outcomes of a non-GCB DLBCL. The next slide, please. This we have talked. Next slide. So whether addition of lenalidomide to addition of non-GCB, does it help? So there was again no difference in OS and PFS in the non-GCB type, and that was again not a very positive study. Next slide, please. So this is an interesting study that is again published last year only. Venetoclax for patients with BCL2 expressing diffuse large B-cell lymphoma, and that too upfront. So there is some data that is published previously for relapsed refractory setting, and this is a data for newly diagnosed DLBCL with a BCL2 expression. Although in this study, the BCL2 expression on IHC was seen in close to 60% of the patients. The dosage of venetoclax that was used was in cycle 1, days 4 to 10, 800 milligrams. And from second cycle onwards, it was used at the dose of 800 milligrams for days 1 to 10, along with rituximab CHOP, R-CHOP regimen in a 28-day cycles. The end of treatment CR rate were good, 70%, considering they were high risk DLBCL, BCL2 positive. So the median follow-up of 32 months, the trends observed were in favor of adding venetoclax R-CHOP. So why I say improve in favor of adding venetoclax, because in this study what they did was the next slide please. What they did was they had retrospectively compared the data of this trial to the Gazyva CHOP regimen, and they had compared this retrospectively. So as when it was compared upfront GCHOP versus Gazyva CHOP versus venetoclax CHOP for those high-risk DLBCLs, the data favored in favor for using venetoclax over GCHOP, and that was a significant advantage in terms of progression-free survival. The trend was seen essentially in the favor of using venetoclax upfront, especially for patients who do express a BCL2 on immunohistochemistry. Here, the cutoff that was taken for BCL2 was 50% on immunohistochemistry. The next slide, please. So whether addition of maintenance is going to help us in any way. Remark study published last year. Next slide, please. So for those patients, addition of lenalidomide for those patients who are elderly, and this study, the Remark study, showed that it recruited close to 450 patients, and what was seen was the observation made was that treatment emergent adverse events were significantly higher in the lenalidomide arm as compared to the placebo arm. That led to significant dose reductions in the lenalidomide arm, although there was the benefit in terms of progression-free survival in the lenalidomide arm as compared to the placebo arm. The next slide is more interesting. If we see the top two curves, next slide, yeah. If we see the top two curves, the red and the orange curves, these are the curves that had used lenalidomide either dose adjusted or non-dose adjusted, and these were significantly better for the as compared to the placebo arms. So addition of maintenance for elderly DLBCLs, and essentially they are those who are high risk, were not candidates for intensive treatment regimens. For them, R-CHOP followed by a lenalidomide maintenance might be a strategy that may be incorporated. So the next slide, please. I'm coming to the end of this talk, and these are the various sort of molecules that are still in pipeline in the research phase. There are still phase 1-2 data that is available for the use of anti-PD-1, anti-CD40. There is still a role of BiTE antibodies that is still coming up. The next slide, please. And these are various small molecules that are in the pipeline, including the JAK inhibitor use, the BTK, the idelalisib molecule in the use of relapsed refractory setting, essentially as of today. But slowly and steadily, as we are getting more mature data, maybe these molecules slowly can come into the upfront treatment practices as well. Next slide, please. And that's the last slide. So when treating DLBCL in 2022, probably what we aim is to identify the high-risk DLBCLs. Maybe it is in the form of double-hit lymphoma, triple-hit lymphoma, or it is in the form of the higher IPI score. We need to individualize based on individual experiences and maybe collation of data that in our context, which are the patients who truly deserve and going off the road from R-CHOP to either intensified regimens or addition of some novel agents to the upfront treatment regimens, or considering addition of maintenance treatment. So that is what needs to be individualized, and based on the data from our context, patients with high EPI mutated c-MYC may be benefited by intensive regimens. Of course, there are a lot of co-variables that exist in this setting. Modification of the upfront therapy by addition of certain novel agents, as discussed, may be considered for non-GCB type DLBCL. Lenalidomide maintenance for case-by-case basis, especially so far the data is essentially for elderly patients. And the data of brentuximab, although it is very encouraging, but the toxicity profile needs to be considered, including both physical and financial toxicity. And probably that will, these are the data that probably guide us in the coming future, that what will be the best treatment options in improving the outcomes of those high-risk DLBCLs that we are losing as of now. And with this, I come to the end, and thank you. Last slide, please.
Thank you, Dr. Meet Kumar, for an excellent presentation. For EAR, this is a patient that you will choose for, say, land maintenance.
Sorry, sir. Sir, your voice is cracking, sir.
Am I audible?
Yes, sir. Yes, sir. Now it is better, sir.
Not audible?
Sir, now it is better, sir.
Okay.
Now we are able to hear
what
you.
I was saying was, okay. So what I was asking basically was that if you have a diffuse large B-cell lymphoma and you have categorized it, which patients by the data that you have would be candidates for DAR epoch?
So, sir, as of today, what if I'm able to correctly understand, sir, you're saying which are the candidates for DA epoch, ARDA epoch regimen as of today?
Yeah.
So, sir, what we are doing as of now is we are doing a double expressor analysis as of today. We are doing CMYC on IHC, BCL2, BCL6 for all patients who are newly diagnosed to have DLBCL. And for those patients who have got a clinically high risk features of double expressor lymphomas, we are trying to get a FISH analysis done. But that is, I can say, that is being practiced in close to 20% or 30% patients of all those patients who have this. Once we identify them as a high risk based on these parameters, definitely, yes, we try to counsel patients, and definitely, I'll say we have 4 or 5 patients who are on a dose-adjusted epoch protocol as of today. And the outcomes, yes, some of them, like offhand, I just remember one patient who has relapsed close to 8 or 10 months after the initiation of the dose-adjusted epoch protocol, but others so far have been doing favorably well. So yes, sir, these are the parameters at least based on which we try to escalate the treatment intensity to dose-adjusted epoch over and above the RCHOP regimen. Sir, I think your experience would be more valuable for listening to us, sir.
No. I think the younger generation has a lot to teach us now, because many of these things have come up recently, and we are changing our practice.
Meet, can I comment?
Yes, Dr. Saurabh, please welcome. I was going to ask you.
I think my video has some issues. My daughter is going to sort it out. Good afternoon, sir. This issue of ARDA epoch versus no ARDA epoch and only CHOP has been debated day in, day out in our department in Kolkata. So some people believe ARDA epoch is not as great, not major benefit and side effects if you follow the data. But some people are a strong believer, no, epoch may be a better, as most of us only have one chance, not more than one chances, if at all we have a chance. And if you see the forest plot from the comparative analysis in high IPI group, at least it is favoring epoch. Now high IPI, many people here believe MIB index may be a marker to say CHOP is inferior as compared to epoch, like 90% MIB with DLBCL. Now it's a tough job. Sometimes FISH may be plus minus negative positive. Then we err on the epoch side provided the patient is tolerating. But otherwise, if you see the literature, there is no clear advantage of epoch over CHOPs. But we are using it right, left and center.
I agree with you. In fact, I think recent data on diffuse large B-cell lymphoma says that there is no advantage of R epoch over the CHOP. So that's why I just wanted to stimulate you that are we actually following people, or are we trying to do what is actually right for our patients? So more may not be better. At least so far, it has not always been so.
Yes, sir. Now, none of the IPI risk criteria uses MIB index. And now MIB index is so variable. One lab says it is 85% and one lab says it is 90%. Now, it is a difficult choice sometimes. And so it's not easy, sir. But, and we don't have much trouble giving epoch.
So what is your policy, Dr. Saurabh, at present at Tata Medical Center?
Clear-cut policy myth there is not there. If you ask a clear policy where all the 4 consultants agree, it is not there. I don't think any institute has a clear policy for any of the diseases in any of the institute in this country or even abroad.
Sir,
If you ask an expert, he says, I will not use, but I will believe. If you use it, it's not wrong.
So there is a patient, young patient
or other
with,
way wise also. So
if-
there is
if
no
there is a-
clarity myth.
if there is a young
So-
patient with high IPI index and he is CMIC positive 60%, BCL2 positive 45%, what would be your next step?
Epoch. I myself would use epoch, but probably Rina Nair madam may say no, CHOP is good enough, and there is data to prove both. So it is not easy.
So
Provided you have a
which analysis
second
for all
choice of
patients?
going. Yes.
Can I come in? Right.
Yes,
Sir,
So,
please.
yeah, so it means that there is lot of things that we need to learn and understand for each individual patient. And these are not only, I mean, we were talking about the outcomes in terms of overall survival and the progression-free survival, but there are many other factors that we need to factor in while you are taking a decision to treat these patients. And
Yes.
I'm sure that it actually requires a good session with some old timers and the youngsters to really come to some kind of a conclusion that as to what should we be doing in settings where you are not taking patients on a protocol. I mean, that is important because that is what we need to do in our country also. We need to
Yes.
have some data of our own as to how do our patients respond to these aggressive regimens. Our patients are generally in terms of performance status are poorer. In terms of nutrition, they are poorer. So we need to consider all those things also. I just wanted to ignite a debate. We were not having a debate since morning. And now we can, I think we are already past time. So let me invite Dr. Saurabh Bhave, who is a senior consultant in clinical hematology and BMT at Tata Medical Center, Kolkata, to start the panel discussion.
Sure, sir. Thanks a lot.
Sir, can I
Somebody
just
from
say
the
one
organizer
statement,
team,
sir, if you allow me, sir?
Put on my presentation.
Sure.
In the meantime, can I just say
Right.
one statement?
Sure, you do.
Dr. Saurabh, he's just like a stormy wind. Sir, he cannot be invited. He self-invites most of the times, and it's the beauty of him, sir.
Okay, and Dr. Saurabh will call the panelists, right?
Sure. So thanks, Ankur. Thanks the organizers and the sponsors for inviting me for this session. So can we have the next slide, please? So I invite my panelists, Dr. Riya from Nagpur, Dr. Arun from Mysore, Dr. Sanjeev. Is he there? Is Sanjeev there? I'm not seeing him.
No, sir. So Dr. Sanjeev sir is not there.
Sanjeev is not.
He's not
Is
responding.
Mahadev
Yeah.
there?
So he will be joining.
He will be
Dr.
joining.
Sanjeev had some family issues. He might not be there.
Okay. And Dr. Suresh from Hyderabad, is he there? I think I have seen his name. And Dr. Unni S. Pillai from Kottayam. So are all there. And this session is open for everybody. Huh? There is no specific person whom I'll ask a question. Anybody can answer who has an opinion. So case number 1. We have a 54-year-old gentleman from West Bengal with a modest socioeconomic profile. January 2021, he comes to us with a left-sided cervical swelling since 25 days and increasing in size with intermittent low-grade fever. Next slide, please. He has a good performance status, large cervical nodes. Rest of the examination is normal. Next slide, please. His peripheral counts, everything is okay. There is some rouleau formation. Other than that, everything okay. Next slide, please. The biopsy from the left cervical node shows a Hodgkin's lymphoma, which is CD30 positive, FACS positive, negative for 15, 20, 45, and 3, supporting the above interpretation. Next slide, please. And PET scan shows disease above and below the diaphragm with some right lung mass abutting the D10 and D11 vertebra and probability of marrow involvement as well. So essentially stage 4. Next slide, please. So referred to a hospital near his house for further treatment as TMC was far away. ABVD till 2B. Then the PET scan showed that new onset nodes in the submental region and in the left subclavicular fossa. Now, he was again advised for an interim PET. So this was a clinical picture when he had a new onset node, advice for interim PET. Next slide, please. Mild diffuse uptake in the visualized skeleton and interval progression at bilateral cervical nodes. Next slide, please. So these are the comparisons between the two PET scans. If you see the bone marrow is now showing diffuse overall, which probably is not an involvement. Otherwise, it shows something called as a partial response. With some areas, it is showing that the node, the SUV may be a little bit increased, and also there is a clinical increase or new node in the submental region. Next slide, please. So he came to TMC again for an opinion. We advised a biopsy, but he did not get it done. He continued ABVD till 4B at that center. And again, the nodes were persistent. Next slide, please. So one more PET scan was done, which showed stable disease. No major increase in the disease as compared to the interim PET scan 1. Next slide, please. So now we decided to do a core biopsy, also agreed for that. And so it was a diffuse involvement of the lymph node by sheets and nodules of small to intermediate sized cells, atypical cells, clumped chromatin, sand cytoplasm admixed with para-immunoblast and occasional pro-lymphocytes. Next slide, please. So now this was consistent with a CLL type picture. Ki was around 25%, P53 strong positive in 90% of cells, and they were CD20, CD5, PAX5, 23, everything positive. Next slide, please. Now the previous biopsy which showed Hodgkin was rechecked and it was confirmed to be Hodgkin without any morphological or immunohistochemical evidence of CLL. Next slide, please. So question to the panelist. Is it a concurrent HL and a CLL as a composite lymphoma? Is it CLL and SLL with HRS-like cell and not a true Hodgkin? Or is it CLL transformed into Hodgkin lymphoma? Anybody can take up the question.
All three possibilities are always there, sir. Very difficult to comment based upon this information, but usually a CLL with HL upfront as a composite lymphomas, we expect some better responses. So probably that is not the case. So it must be one of the transformation is a clinical guess. I mean,
Right.
leave it to other panelists.
Right, Suresh. So tough. No. And will it really make a difference in your treatment essentially?
Yes, the options are there. More options are there for CLL, right? Probably if it's a transformation, probably our line will change slightly.
Okay. Meet, any suggestions? Is Meet there? Any other panelist? Any opinion?
So Dr. Ria here.
Yeah.
As always, your cases are really intriguing and one of a kind. Very challenging case, I would agree. So the first PET CT that was done, that was showing more of a uniform SUV max throughout. But the other one, if I remember well, there were some areas that had a low SUV max, some areas that had a very high SUV max. So again, both possibilities are definitely there. This could be a composite lymphoma or this could be CLL, which was transformed into Hodgkin's. But my bet is more that this could be a composite lymphoma, looking at everything. But one thing, the second biopsy that was done, I think that was a core biopsy rather than an
Both were
excision
core
biopsy.
biopsies. It was never excision biopsy. So
Okay.
that's the point.
Challenge.
So that could be one thing that would not maybe properly guide us. I don't know. If we had the full node, maybe we could see whether that was a composite lymphoma
Maybe.
or whether it was something
So in
else.
such a situation, if it was a complete node biopsy and if you were seeing CLL and HL both in the same nodes, what will you treat? Will you treat one or both?
So I would treat the higher grade lymphoma. I don't know if you've mentioned, so I would treat the Hodgkin's here. I don't know if you mentioned the molecular, the mutation status, the CLL, IGVH mutation status, or any other fish markers.
I'm
whether
not
that
sure whether the treatment for CLL depends upon the mutation stated at diagnosis. It depends
Yes.
upon the clinical features maybe, but definitely
Definitely.
Hodgkin has to be treated. There is no
Hodgkin
doubt
has
about
to be
it now.
treated. Agreed.
So
Absolutely.
anyone else has any other suggestion? Probably not. Can we move on to the next slide, please? Next slide, please. Yeah, so these some theoretical information. There are types of Hodgkin's transformation in CLL, type 1, type 2, and probably this case represents type 2 transformation. And in type 1, there are HRS cells scattered in the background of CLL. And type 2 is that they are totally separate from the CLL cells, and B cell markers are negative in the HRS cell. So these probably look more like a type 2 transformation. Next slide, please. So Richter transformation is diagnosed when RS-like cells are typical by 30-15 phenotype, variable 20, and occur in an appropriate polymorphous background of small lymphocytes, epithelioid cells, eosinophils, and plasma cells. And majority of these are EBV positive. These are Richter transformed HL cells are EB positive. Next slide, please. So he had probably Richter transformation at diagnosis itself, probably from a CLL background. So how common it is to have a Hodgkin as a Richter transformation at diagnosis? Anybody can take up the call.
Very rare, sir. Very rare.
Very rare. So probably I am seeing this for the first time. Subhash Verma, sir, any comments on this?
I haven't seen one.
So that must be, it must be really, really rare. With such a vast experience, if he has not seen one, then it must be really, really rare one.
Sir, I'm Dr. Mahadev here. Can I add a word, sir?
Yes, Mahadev.
There was one article in HEMATOLOGIC 2021 where they have reported around 40-45 case series of Hodgkin lymphoma transformation in a CLL, where they considered that to continue with the ABVD rather than changing the line of therapy to CLL. I mean,
Right.
I just mentioned, I went through the article.
Right. Agreed completely.
Yes, sir. Yes, sir. Thank you, sir.
Yeah. Next slide, please. So it's very rare, less than 4.4%. It's extremely rare to get a Hodgkin transformation. Next slide, please. Now, what is the stage of Hodgkin lymphoma in this patient? Now, if you have a CLL background, can you really stage the Hodgkin? Any takes?
That's a $1 million question, sir. SUV is such a soft marker which we don't have any data. Probably that is the only thing on which we have to rely. So
Right.
other than that, very difficult to answer this question.
So probably not. But if you see the two PETs, initially there were focal lesions in the bone marrow, and now probably it's a diffuse, generally post chemo, anemia, or you get a diffuse uptake. So probably it was a stage 4 because of the lung anyways. Lung mass, we don't know what it is, but at least if you see the bone marrow part of it, in retrospect, you can say this may be stage 4, but not an easy call. Completely agreed. Next slide, please.
So can I ask a question?
Yes, sir.
So if you do not have background lymphocytosis, how do you make a diagnosis of Richter's transformation?
No, sir. This was all in retrospect, sir. This is all a case that what is actually happening. Now the twist is over the, I have not put it in the slide. So there is one more twist to this now on top of everything. So I am really pissed off with this patient. So I am not sure, sir. You can suggest us whether this all discussion is totally going haywire or is it really okay discussion?
No, I am not suggesting anything, but if you do not have peripheral blood lymphocytosis, making a diagnosis of CLL itself is very difficult.
Yes, sir. Agreed.
SLL, sir.
Maybe
Sorry?
SLL into Richter.
SLL,
We
sir.
can put it in that word.
So I was coming to that. So if at all, if this patient had lymph nodes for some time, you would say that it is an SLL that has gone into a transformation. We cannot call that it was a CLL that has gone into a Richter's.
Right, sir.
Completely agree, sir.
Upfront, we had not done a bone marrow, sir. So we don't know, really speaking, whether marrow had at that time CLL or not. We had not done a marrow because it was Hodgkin, two spots on the PET scan and say, okay, this is Hodgkin, PET is more or less okay, don't do it. So when you got a CLL, now everything is being done retrospectively. But I agree, sir. This is the SLL into Richter, maybe. Yes, sir.
In general, in CLL, you would have peripheral lymphocytosis.
Yes, sir. But he had some rouleau formation. Now Hodgkin to get a rouleau is again uncommon. So if but soft points here and there. So I'm not sure whether that rouleau should have triggered us to think that is something else going wrong along with Hodgkin at that point in time. I am not sure. And that would not have changed our treatment as well.
Right. I saw that, and rouleau is an indicator of some kind of an abnormal immunoglobulin.
Yes.
Right. Whereas it's not a usual feature for most of the CLLs.
Yes.
It is a usual feature for abnormal immunoglobulins.
Yes, sir.
So even that would not really suggest as to what is actually happening in this patient.
Right, sir. Right, sir. So next slide, please. So in now when you get a CLL after that interim scan, shall we now continue treatment for Hodgkin, or shall we say that now there is no need for treat Hodgkin? And if you want to continue the Hodgkin treatment, what will you do? Which treatment will you use? Any comments?
Sir, can I add a few points?
Yes, yes, Udnay.
Regarding stage, will it going to make any difference for this patient at this point of time by knowing the stage?
No, I didn't get you. Please come again.
So by knowing the stage of Hodgkin's, does it going to make any?
Not at all.
No, not at all. And
Just
again,
for some theoretical, we have, because patient wants to know what is the stage of the disease.
Okay,
he understands stage 4 is bad and stage 1 is good. That much patient knows. So just for his comfort and for our comfort also, what are we really treating?
And now what we are dealing with is a transformed SLL. And we all know that the prognosis is going to be bad. And again, we have a progressive disease after ABVD. So ABVD may not be a good choice now. So if you need to treat him, probably an escalated BCOP or something would be my choice. And regarding transplant, I have no idea. It also need a board discussion on whether to go for a highly intensive treatment and go ahead with transplant for this gentleman. So
I a little bit disagree with that, because now probably we have Hodgkin or we don't have Hodgkin. That also we don't know. We did one biopsy which is stable or progression, it's CLL. So Hodgkin part has been really treated with ABVD or not, that we are not sure. That is one. Second, how many biopsies are we going to do? 1,
So
2,
can I
3, and
interrupt?
from which areas? Yes, Ria.
So PET CT, like I said, if I remember well, there were two different, one was very high uptake, one was low uptake. So whether we could biopsy one of the high uptake areas, one of the low uptake areas, whether this is a discordant lymphoma, two different diseases that we are dealing with. Just a thought. Just a thought.
Right. Any more suggestions from anybody? Mahadev?
yeah. So my thoughts will be, after ABVD, you have many of the active agents for most of the lymphomas in ABVD. Even CLL should not progress on ABVD. So you have a progressive Hodgkin's or progressive SLL on ABVD, and you have all the indication to treat an SLL. So whatever we are giving continue with ABVD will be suboptimal.
So you will give escalated BACOP and then do 4 cycles.
My thoughts will be that this is very tough and challenging. We never come across with such a scenario in my lifetime. I have not seen or heard of that. Or should we add rituximab along with the ABVD? All those things are going into my mind, but I don't have a definitive answer to that question.
Don't have a definitive. Dr. Verma, sir, can you say that which way shall we go?
So what we are really saying is that the second lymph nodes that have appeared later are more like CLL, and that there was a Hodgkin's lymphoma. Now, I would go at least and biopsy both the ones, because if there's a progressive disease, then you have to change your treatment line in any case.
Yes, sir.
So my personal thing would be to look at the area that has got a high PET values, and then maybe change if you really think that the disease is persisting or progressing.
Okay, sir. Okay, sure, sir. Next slide, please. So the essentially treatment should be continued any Richter type of this treatment, and ABVD is the standard approach, as Mahadev also has pointed out. So next slide, please. So is it necessary now to look for clonality between the CLL and the Richter? Is it important in your treatment algorithm? And if yes, how will you look for the clonality assay with whatever tips we have? Anybody can take. Ankur, Meet, anybody.
Sir, as of now, till if we can see, we are dealing with the case of SLL, which has there is a Richter's transformation to Hodgkin's lymphoma. And if we can go through the two PET scans, the first PET scan, the cervical biopsy SUV was very high, it was about 30, and rest of all where the SUVs are on the lower side. And the second PET scan, which has shown the SUVs were they are not very high, it's around in the range of 5 to 6. So it seems that the Richter's transformation of Hodgkin's has been treated as with ABVD. And I do agree with the panelists that ABVD, many of the molecules will work in CLL also. But this case has not responded with ABVD as SLL. So we have to look for now with the diagnosis that if it is SLL, we should proceed with the lines of CLL or SLL treatment with the second line as relapse refractory or something like that. The CLL has not responded to the initial line of treatment. Now we should proceed as SLL.
Okay, so will you check for clonality, or we will say no need, now there is no point in doing
Sir, we have already done, sir, IHC has already been done. So in one sense, yes, the clonality has been diagnosed as SLL. So to get a clonality, just to know that is it a clonal proliferation or there or not. In the second biopsy, we have already done IHC. And on the peripheral blood, as sir said, the counts are less than 5. So even if the clonal cells are there, we can't look at it as CLL, more or like clonal lymphocytic proliferation, something like that. Not.
Sanjeev is there. Sanjeev has joined.
So again, I have a doubt. Now, while you give while the patient was on chemotherapy, it also matters when you have done the PET CT, how many days after the last dose of chemotherapy the patient for CT, and then very skeptical in interpreting the PV values in the second scenario. First time it's fine. Interim PET CT, we should be very careful. When you have clinical program, you have new nodes, you have clinically enlarging nodes in the neck. Even if the SUV is low, there is clear-cut progression. So that has to be taken with a pinch of salt.
Yeah.
A very difficult case, sir. I don't know.
That's very true. So if I want to say that maybe the cell of origin is the same, then I would try looking for the clonality. And at the same time, I would do some molecular studies for the CLL also to prognosticate it.
The IHC in the CLL shows P53 as very strong positive.
Okay. Then that I
mutated CLL. That's why it is terrible.
That is very bad. I missed it. Yes. 53 positive is a bad disease. We need to treat it. Yes, sir.
Next slide, please. So there is something called as Richter transformation. Mostly it is large B cell, and the second it may be Hodgkin. Amongst the Hodgkin, most of them are de novo Richter from CLL, but around 40% may be clonally derived from CLL. Next slide, please. Normally, it is done because the clonal RT, the clonal Richter transformation may benefit from novel treatment strategies and subsequent stem cell transplant. Now, it has to be done with IgHV sequencing or analysis of clonal Ig rearrangement pattern. We don't have many of these unless some institutes may have in research setting. The kappa lambda can be done on both these tumor tissues. And if both are different, probably we are not in a position to say whether they are really clonal or non-clonal. So for most of us, the relationship between the RT and the underlying CLL currently is not assessed at many of the centers because subsequent treatments are not so easy to judge. But there is some information that yes, clonal RTs require a little bit different treatment as compared to a non-clonal Richter transformation. Next slide, please. Next slide, please. So now how to monitor this patient? So essentially we completed the 6 ABVDs, contrary to the thought process of the panelist. And now how to monitor him now with the SUV, with clinical features, with the ESR, or with what?
The simplistic method will be to monitor him clinically.
Clinical.
And so I am sure that he would have progress in another couple of months' time. I am expecting.
I am not sure. So next slide, please. So PET scan maybe, may not be, because we don't know what's happening really speaking and which node what is happening. Next slide, please. Now shall we treat his CLL? A new node has come. Shall P53 IHC is strongly positive, and on ABVD a new node is cropping up. Other than that, peripheral blood, organomegaly, general features, laboratory bike, everything is normal. So in that situation, will you treat his CLL?
Sir, can you give me some more information, like was there a 17p deletion or something like that, or if you have
peripheral blood fish, there was nothing in the peripheral blood. Now, if you have a very strong P53 positive on the immunohistochemistry,
that indicates
that
17.
itself means that the P53 must be mutated. P53 is which is a short half-life. So if you get something, it is mutated. So that's for pretty sure. We are pretty sure that it's a bad CLL. So are you going to treat it now?
Definitely yes.
Sir, Dr. Mahadev,
Any other thoughts?
I just forgot the age of the patient and his
54.
medical fitness and any
Fitness,
end
fit, no comorbidities. We don't routinely do the IGHV, but we have done the P53 IHC.
I think we will treat him, sir. Upfront CLL, no, but in a transformed case, I think we should treat maybe with
So in the see, if you have a marginal zone transformed into DLBCL, normally marginal zones are not treated. CLL into Richter, CLL, unless there is a clinical need, we don't treat. So here we are saying that there are nodes and there is so-called progression on ABVD with the IHC, which is P53. And most of the panelists think that he should be treated with some drug, right?
Yes.
Right, probably.
Right.
Yes, Suresh, any opinion?
I think he should be treated for the CLL, sir.
CLL. Okay, next slide, please. Let's see. Probably yes, large nodes are present and most likely it's a mutated CLL. So I also agreed at that point in time, yes, this gentleman needs treatment. Next slide, please. So ibrutinib was started essentially for him because of the P53 strong positivity, and we have the generic version and which he could afford. And within 2-3 months, all the lymph nodes vanished completely. Right? So he was quite well. Next slide, please. Next slide. Next slide. Next slide. Right. Now, supposedly, if he relapses and if the biopsy now shows Hodgkin, how will you treat? With an auto, with an allo, or what? Any suggestions? This is hypothesis. He has not relapsed as Hodgkin. This is my hypothetical question.
So the remission is achieved already.
Clinically achieved, imaging wise achieved. If he relapses as Hodgkin, what to do?
Recommendation in this case would have been auto because of the age and multiple things. Because he may not, I mean, even if you do allo, he may not respond well. Is what is a clinical guess sort of thing. Do less harm than not, I mean, sort of thing.
Any other suggestion? He
Sir,
doesn't have CLL, he has SLL still.
I have a question. So you have a richer transformation. You have a probably a P53 mutated SLL. How many of you are for an upfront allogenic transplantation?
So if the lymph nodes, ibrutinib has cleared the lymph nodes completely, then Unni is willing to take him up for allo.
No, I'm not willing. I'm not doing allo. I'm not doing allo. I'm not a fan of allo also. So how many of you are willing to go for an allogenic transplant? Because we know that ibrutinib is not imatinib. The patient is definitely going to relapse. So young patient, in another couple of years, he will be out of that transplant window. And this allo is going to treat both your Hodgkin's and SLL. So how many of you, I mean, this is a very tough scenario and you don't get an evidence for this in such scenario. So how many of you are for doing an allogeneic transplantation?
There's a high probability that you can kill a patient with allo-HCT. So Subhash Verma, sir, wise words.
I'm not very sure. It's a very difficult one. So like any other Hodgkin's, what I would look at is when does the relapse occur in this particular patient, right? If it is an early relapse, then in any case, transplant would be indicated in this patient. If it's a late relapse, then you'll have to take a call again.
Right.
So I'm not really very sure about allo with in a person who's otherwise completely all right and with a kind of morbidity and some chance of losing life at this particular time.
Right.
Now,
Right.
if he relapses, then that is the time for us to discuss that.
Any other suggestions?
Sir, request you to conclude your panel discussion in 5 minutes. Thank you.
Are Ekta, this session is time
Yes,
bound.
sir.
Huh? We cannot
Yes.
extend it by 10 minutes at all, at any cost.
Okay, sir.
We cannot extend.
That
can
is
actually.
Ankur. Dr. Ankur will just get
Only
back to
2-3
you,
more
sir.
questions. So anyways, we go on to the next slide. I will tell you the latest update about this patient. Next slide, please. Right. Next slide. Next slide. Next slide. Next slide. Next slide. Right. So this patient was doing well, and again after 6 months, the lymph node started increasing in size. I did biopsy from 2-3 different nodes, and now it's a large B-cell lymphoma. So how will you treat him now? He will come to me on Wednesday. I have to give him some answer. Anyway, the expert panel is available to me across the country. So I can tell him that yes, expert panel opinion taken. How will the DLBCL be treated now? RGDP, RDHAP, or I don't know what, with allogenic stem cell transplant because of the bad underlying CLL. I think that probably I would do that. But I want to know from the audience, from the panelists also, how will they treat him now?
This is a suspected, no, sir. When we discussed itself, this is a suspected. So, even
so initially Hodgkin, then a CLL, and now a large B-cell lymphoma. He has used some adriamycin. 6 adriamycins is 25 mg per meter square into 12.
So whatever
around
we
300
do,
milligrams of adriamycin got over already. We have 150 milligrams of adriamycin available with us theoretically.
so whatever we do, the prognosis is going to be bad.
Agreed.
And to that we need
How
to
will you treat him? There should be some, otherwise he will be anyways bad. If you don't treat, he will die.
Best bet would be to go ahead with a salvage RIs or RD hub, and then then
I go even milder, sir. I go even milder. I may go with
RIC allo.
Right. And probably a RIC allogenic transplant.
Yeah, RIC and allo.
And what is your current thought process on a donor? If he has a match related sibling, will you go for a haplotransplant?
I don't know. Someone who is, I am not doing many of any allos now. So anyone
GPJ, what is the thought process? Is Meet around or he has left?
So Dr. Meet, I think left, sir.
Meet has left. Okay. So Ria, thoughts? I am not sure.
It's a very, very, very difficult case. I totally agree. So my take also would be some salvage therapy and RIC transplant. But if I don't have a match donor available, I really don't know whether we should take him for auto or allo.
Right. So anyways, I'll ask in the department also.
Are you okay for auto in this case?
Pardon me?
Are you okay for an auto transplant in this case?
I am not sure. Auto is not going to help. Anyways, in P53, auto is a bad thing. And this is more or less now becoming Richterish. One Richter in DL, Hodgkin and one Richter or whatever, composite, whatever you can say. essentially he is heading for a very tough time now.
But sir, the chemo you are planning for him, and after the chemotherapy, how will you monitor that the patient is in remission or not? Because it is SLL. So how
Now,
to?
essentially, he will undergo bone marrow test to look for presence of CLL, a PET scan. This is all a clinical increase in nodes, a PET scan, probably a salvage without adriamycin, because it will be difficult for him in the transplant as well. So then there is a choice, GDP, JMOX, DAP, IS, whatever is your policy of the institute, and allogenic transplant, which is a RIC regimen. Now, I'm not sure whether if he has a match related donor, shall we go with MRD or shall we go with haplo, saying that haplo has a more graft versus lymphoma effect theoretically, even though there is no clear recommendation of using haplo over a MRD donor. So I'm not sure. Let me ask Dr. Maman sir, what is his opinion? Subhash Verma sir, what is your thought? With the DL Victor now, what shall we do? Because he may take multiple opinions from the people out across the country.
On a research perspective, P53 monitoring will tell you whether he is in remission. MRD monitoring for P53 by any of those genomic methods would be the ideal thing to.
I am not sure. Is there any information regarding quantification of P53?
I don't know, sir.
I don't think so. IHC, it's variable. Some may say 50, some may say 70. I am not sure. Is P53 a robust enough marker to look for MRD in any ways? I have never done it. It's a prognostic marker, definitely. There is no doubt about it.
But in this scenario, with CLL, P53 is again we are detecting by PCR in the blood that indicate residual disease. That is the logic. Other than that, there is no evidence to suggest.
Okay. Let's see. Next session we will discuss the further workup and the treatment for this patient.
I would say even if the P53 is negative now, P53 per se is a very poor marker. So even if it is negative now, we should take him as a high risk disease.
Yes.
Yes. Sanjeev is saying haplo is not a good option. Sanjeev, you are not audible, or are we not audible to you? Anyways, we have come with this discussion. We should finish it off and then finish the session. Verma sir, final comments. We will close after that probably.
No, I'm not really very sure. I'll have to think about it, but I'm not certain about what should be done. Obviously, you will first treat and see what is the response like.
Yes, sir.
And then decide, rather than just, I mean, both the options are open as far as I'm concerned.
Sure, sir. Thank you, sir. Thanks a lot. I thank the panelists for actively participating in this case and at least helping me out. Sometimes not finding an answer is also an answer for me. That yes, there is no answer. The patient feels satisfied that there is no answer. That also is an answer. So over to Ankur and the organizing team.
Thank you, sir. Thank you, Subhash, sir, and thank you all panelists. Subhash, sir, one line that the question which you have arised regarding the RDIPOC. While I was at MD Anderson, Dr. Kantarjan words was in a discussion, in a tumor board discussion. So they are using RDIPOC in the patients, those who have more probability of having CNS disease, like Walder rings or any cervical lymph nodes are involved, or double hit or triple hit. Then PMBCL and Burkitt's. These were the patients in which they are opting for RDIPOC. Rest they are not doing.
Okay, thank you.
Thank you, sir. And sir, at the end, I would like to thank all the dear colleagues. A big applause for all the learned faculty who have presented today. And I really thank Dr. Priyanshu Chaudhary, who have discussed the current indications and recents in TKI and TFR. I need to thank Dr. Sachin Yadav also, who has discussed regarding the venous SS, which is really has markedly reduced the infections and the need of guidelines in Indian setting for the PICC lines. And Dr. Dibanjan Hadar, who has discussed regarding the details and pathophysiology of the mucositis with treatment and the management. And Dr. Isha Kaul, who have discussed relapsed ALL patients, and sometimes it's very difficult to have salvage therapies in these patients and regarding the special interest in inotuzumab for the relapsed refractory ALL patients. Dr. Meet, who have discussed the diagnosis and the management of high-risk double-hit lymphomas and various treatment regimens and the outcomes for the same. And Dr. Saurabh Bhave for the wonderful discussions, and all the panelists, Dr. Riya, Dr. Arun, Dr. Sanjeev, Dr. Mahadev, Dr. Suresh, and Dr. Pillai. And a very special thanks to Dr. Verma, sir. And at the end, there was one message from the bar that if in case anybody wants to have the venous assess sessions or any accessibility, so they can contact them for their centers. And not the least, thanks to all the scientific partners and the Horizon for organizing this. I acknowledge the academic support from all pharma who have participated, and thank you everyone. Looking ahead for the further discussions and things.
Thank you. Thank you so much. Thank you everyone for joining, and thank you for the wonderful academic feast. Stay safe and have a nice day.
Thank you.
Goodbye.